Thank you so much for everybody showing up. Truly appreciate it. We're always privileged to get these. Thank you very much for everybody for showing up today. And for those who are online, thank you so much. We started putting this presentation together back in January. This is our second seminar that we're doing. There's going to be a couple more throughout the year. We're very privileged to have two incredible speakers today. Dr. Lee, some of you may know from Sunnybrook Hospital MS Clinic. We're completely privileged to have his time today, his expertise. He's going to be sharing a lot of information with us. And all I can say is that if you have any questions, I spoke to Dr. Lee. If you want to wait till his presentation is over, you all have cards. Please write down your questions. And then when he's finished the presentation, then he will answer your questions. Thank you so much, and enjoy the day.
Well, firstly, good afternoon. A pleasure to meet all of you. I thank Mr. Buscaglio and the MIFE MS family for organizing this event. The Sunnybrook MS Clinic very much thanks any ongoing support as well to our clinic and these opportunities to try to learn about this disease together and to manage it together. To those that are online, again, welcome. And I hope this afternoon would be of some benefit to all of you. To all of us, in fact, and I can learn from some of your questions as well. It's a Saturday afternoon, so it's a time committed on everybody's side, and I hope it will be a useful and fruitful time. I tend to speak a little fast. I'll try to slow down. Please feel free to write down the questions. As I said, if something's really not clear, just put your hand up, and I'll try to clarify if it's not very clear. So we're going to do a little tour de force of MS. I'll try to bring you some up-to-date information from what we know about this condition. And so it'll be a review of MS if I can. And often people say, you know, doctors and MS and different diseases, how are we influenced? Well, here are all my associations with the MS industry. I hope you can appreciate that I've been involved with almost every single one industry, so hopefully there'll be no bias, because I hope I'm not going to try to push for one drug or the other. I'm trying to give you as objective as I can all the evidence from all the agents that are involved. What will we do? I'll look at some of the controversial issues of MS. Among them will be potential causes of the disease. And then I'll talk about the clinical features of the disease as well. And so some which you'll recognize yourselves. And then we'll talk about the treatment options that have really changed. I've been involved with MS now about 30 years now, and it's been a dramatic change over the period I've been walking this journey, and it's been quite exciting. From what I had to say to patients 30 years ago to now, it's very different. And so we have seen the differences in people's outcomes over the years, and we are quite thankful, and it's quite an exciting time to be in this field. Now, firstly, MS itself, it's actually one of the most common acquired neurological conditions in young adults. Probably besides motor vehicle accidents in young individuals, this is the most common neurological disease that we see that's quite disabling to people. And it's very common. This is an old slide. They say 35,000 Canadians. In fact, it's probably more as Canada has sort of grown in its population. The numbers we think about is 1 in 1,000 Canadians have it. And that's some people who know they have the disease, some people don't know. They just haven't had the scans or the investigations, or they just haven't had symptoms. So it's a very common condition. People are not alone in this condition. And now what's useful and unusual in the features of the disease is the following. As I can show you on the slide here, this is the female to male ratio. So for some reason, MS is much more common among women. And so if you look at these sort of numbers, it could be 3 to 2, 2 to 1, but there's something to do with the autoimmune process that's much more frequent and among women compared to men. But men do get it for sure as well. And here's an old slide where I'll try to show you the slide. You see this, this is a distribution of age of onset. here's age 10, and here's age 70. And you see it commonly comes on when we're in our 20s and 30s and peters on the way out. So frankly speaking, we actually have young people as young as age 5, getting the disease. And in my experience, we've had people at 75, my first diagnosis. So these things do happen. These are not rigid numbers, but as a rule, it's the disease of young adults. So late teenage years, early 20s, that's when the first symptoms often occur. And that's what we have identified over the years. Strangely enough, there is some predilection for certain racial groups. And especially you heard about these Northern Europeans, Canada, US. With the origin of Canada are people from Europe, so we're not surprised. So there's somehow people that are Caucasian background tend to have certain genotypes that put them at risk for the disease, and we've been able to identify that. But it doesn't mean that other people are excluded. For example, Asians. Asians will be extremely rare, and African blacks, very rare. Those are about 1 in a million to get the disease, compared to 1 in 1,000 from from the Canadian population, which is the Caucasian population. And you have these ranges like in between here, Australian, South African whites. Now we'll find that the Middle East, Jewish heritage, they're all quite high as well. I think as time has gone on, we've been able to identify more and more folks around the world that do get it, but it still remains that certain groups get it more than others. And there's some interesting theories behind this, and which I'll touch upon. This is the raging idea of what's causing this disease. What's the different pathogenesis? And there's a lot of theories. The upshot of it is we do not know, but we do know of certain risk factors. Number one, as I mentioned before, for sure, this top one here, genetic. People from the Caucasian heritage usually get the disease much more frequently than other people from other areas. And we do know, for example, that in certain gene types, they are at more risk. We know, for example, that I told you that 1 in 1,000 Canadians have it. If that person has it, the sister or brother will be about, increase the fold to 3%. So that's 3 in 100. So your fold increases just because you're related. And if you are identical twin, share the same genotype, your risk of getting the disease is 30%. So you can see the risk goes up the more you share the same genetic material. But the most interesting fact is that if you have an identical twin brother, sister, it's only 30%, it's not 100%. So that means it's not purely genetic, it plays a role, it must be other factors. So that's number one, genetic predisposition from certain cultural backgrounds, ethnic backgrounds put you at risk. But the other enticing features have been, is this infectious agent? And I'll touch upon that. So people have always said, is there something that I've been exposed to get MS? And the theories have run abroad over the years of what can cause this particular condition. The one that has stuck up and hit the media recently as well, but we've known that all along, has been people exposed to EBV. This is so people with mononucleosis. So that itself is a risk factor. So if you're from the certain heritage background, cultural background, you've been exposed to mono, you are at risk. But it doesn't mean that mono is a cause. So this is the tricky part in the whole media. So if you look at all the people in Canada right now, and you do the blood tests and see who's been exposed to mononucleosis, it's about 90 or 95% or more. But clearly not 95% of people have MS, right? So it's only a part factor. So it's not the only factor, but it is one of the viruses that we see is more associated with MS. So that's a very interesting sort of issue there. The part of it is a very interesting story that I can share. So, for example, in Iceland, for example, never really had MS before World War II. When the GIs settled in that area, during the war, and the GIs left after World War II, the first MS cases came on probably about 10 years after. That led to people saying, what infectious, that the GIs carry something going on? It couldn't be genetic because they clearly haven't had they have children yet. So that's why just to fuel the idea that something in the environment or in a potential virus has been reported to be involved. So that's just a part of the interesting bit. The third one that's been always in the news media has always been environmental factors. And that's the vitamin D or sunshine factor, right? So people, it seems to be much more common. I told you about the Caucasians, for example, in European countries. The further north you go, the less sunshine you have, it seems you have a higher risk of getting MS. And that's interesting. Because if you take the same Caucasian population and move down south into the equatorial areas, we don't see that increased risk. So people said, oh, not enough vitamin D or not enough sunshine is a big factor. But once more, you can't blame it all on vitamin D. It's not the only answer, but it's another maybe co-variable or co-factor. So we say that people, Caucasian heritage, had mono before, from climate that lacks sunshine, you're at the highest risk. But then not everybody gets it, but that's the highest risk factors. So these are the running theories as to what's going on at this point in time. And let me show you this. This is an old model, but it still holds true. So I told you these three risk factors. Okay, so can we put it together to what's causing MS? So here's a little diagram I'll try to clarify. Here's a picture. If you look at the upper left-hand corner here, this is your normal nerve. This is the cell body. This is your nerve. These are like cables. And in your cable, the way you think of it is like a wire, electrical wire. You've got this rubber around this copper wire in the middle. For some reason, MS attacks the rubber coating around the wire. And so what happens is that if I look at your arrow here, here's your wire that's normal, but you see these little things that are like little scars. So something's attacking the rubber, and this is the cell that's attacking it. For some reason, your own body is creating these cells that are attacking the outer covering of your nerve fibers. Now, these cells are lymphocytes, or what we think are lymphocytes. These are the cells that you and I all have that protect us against bacteria infections. That's normal. But for some reason, it's attacking your nerves by mistake. And if you attack it long enough, what happens at the bottom picture here, you can see that the outside covering the rubber is all taken away, and it keeps on attacking it. Your whole wire can get cut and damaged. And that's what we think is behind the progression. So that's the standing dogma. It's much more complicated than that, but this is the running theory. So how can I try to incorporate my previous theories with this? So they say, let's imagine if someone, for example, has been exposed to, let's say, mono. So the mononucleosis is the EBV virus. And let's say that particular virus has on its surface something that looks like the outer covering of the axon here. So when you get mono, let's say as a young teenager, and we get sick, we get swollen glands, we have fever, but your body gets better. And guess who's behind you getting better? It's your own lymphocytes, your own protective cells. These are the cells that come in and attack the monovirus, right? And the monovirus is gotten rid of, but somehow your protective cells have now a memory of the bad EBV virus. And then you get better, 5-10 years go by, and then suddenly those same lymphocytes, those same protective cells get activated. There's no mono, but then it goes, oh, we are now attacking mono, and they'll attack the nerve fiber outside that looks like the wire. And that's what we think is causing it. And you'll see that most of our treatments are directed to stopping those lymphocytes from attacking your wire. So does that make sense? That's a running theory as to what's going on. Now, this has been a theory that's been going on, I would say, for 20, 30 years. It's been long-term. But, now we're actually finding out not only do these cells attack the outside covering, they will actually attack the inside wire, and some of them will actually attack the cell body as well. So our treatments, although directed towards these bad lymphocytes over here that are supposed to be protecting us, it probably goes much more than that. And then it's almost like a degenerative process where they start attacking many components. Our treatments are targeted here, but now we're moving towards other treatments, targeting towards the other things, the other cells that are being attacked into the cell bodies and even the repair mechanisms. So I'm just trying to give a simplified, but that's where things are moving in our understanding right now. Here's a paper about the EBV. This is exactly I explained to you, but EBV as the exposed virus that gave you the initial attack, and it's now very popular. And so people are even talking about, should we therefore produce a vaccine against EBV? So in that case, can we get rid of most cases? Intriguing. We don't have the vaccine necessarily, but that would be a very enticing idea that if we can somehow get rid of, vaccinate against this virus, then most of us can be protected potentially as one of the real causes. The other one is, remember, vitamin D. I said it's important. There are some jurisdictions where people are seriously thinking of, should we put vitamin D into our water? because that would be a good factor to try to, it's like fluoride in our water. Could that be of benefit? The difficulty is that the data behind all these ideas, they're not confirmed, and it's going to be very expensive. But, and we always worry about the side effects from all these vaccines, for example. So that's why there's some controversies, but this is where the whole field is moving towards, potentially. The next factor I want to sort of describe, and many of you have got to experience the different pathways of the disease. One is here, the type of course. This is still the old classification. It still holds true, but this is clearly changing with time. This is known as relapsing remitting disease. So this is what most people have. And here is a graph that shows time, and here's how disabled someone is. And the idea with relapsing remitting disease is the following. So MS is characterized by you get attacks, relapses. So let's say you lose vision out of one eye, or you can become numb on one side or paralyzed on one side. And then you are affected for a few days, few weeks, few months, but you get better. So that's called relapsing remitting disease, where you are disabled, but you recover. The reality is that most people, when they recover, they don't fully recover. They will always know that after an attack, when they get tired or it gets very warm, they'll feel symptoms. They feel some of the symptoms coming back. That's just from the scar. And unfortunately, that's what happens if you have ongoing attacks. If you can see this graph here, you slowly become more and more disabled. And our purpose of our drugs is to really stop these attacks from happening. So we try to alleviate as much disability as possible. This is the first class called relapsing remitting disease. It's the most common form of presentation of the disease. There's another form where it's called primary progressive, where you have symptoms, but they don't get better. So when, let's say, some people say, I was dragging my foot, relapsing remitting disease, that goes away. But this one with primary progressive means you get the symptoms, it slowly gets worse with time over the years. And so that's a different sort of disease process, we think. The third category is called secondary progressive, where essentially what it means is that people initially with relapsing remitting disease, but given enough time, they no longer have attacks, they just slowly get worse. So that's called the progressive phase of the disease, secondary progressive. So that's secondarily progressive. Things are evolving. Right now, all our treatments are categorized in these different areas. We have certain treatments available for different forms of MS. There is now a push among all the MS clinics in Canada. We're waiting for hopefully the Canadian government to allow changes to say, don't talk about relapsing remitting or these categories. If someone is having activity on the MRI or someone having activity on attacks, that's active MS, and we should be allowed to treat with whichever treatments we have available to us. That is currently a move that's most up to date. In fact, we just put out a paper right now, writing to the government, trying to say in Canada, can we stop these artificial categorizations? If someone has active disease based either on clinical exam or on MRI, can we get access to the stronger drugs right away? So that's just to give you an up-to-date as to what's going on. Here, as I said, the most common type, I'm not sure that you can see it so easily, but relapsing remitting is the one that's still most common presentation initially. And with time, many people can go to the secondary progressive. A small percentage will be on primary progressive MS. What are the symptoms? What are the typical attacks? So that's where it's important. The most common things we typically see are people, for example, they lose vision, something called optic neuritis. It doesn't come on suddenly. It comes on gradually. The people wake up and say they've got a smudge in front of the eye, and with time, it slowly gets worse. And then it lasts for, few weeks, few months, and it gets better on its own, no matter what we do. Some people get weakness. They dragging one leg, dragging one arm. Comes on slowly, and it gets better. People with paresthesias means sensory symptoms. They have tingling one whole arm, one whole leg. Again, it's not something that lasts for a few minutes or hours. It comes on gradually and lasts for a few days, weeks, or months, and slowly gets better. That's a classical sort of presentation we have. Some people get vertigo and so forth. Different things can evolve. Here's this quick video. These slides are sometimes used for teaching residents or other physicians on how to look up the disease. Here, let me show you this very unusual feature. So all of you, when you flash a light in your eye, our pupils will become smaller. It's a normal protective mechanism to avoid too much light, to be too uncomfortable for us. Look at what happens with this patient. So this is where I can tell if someone has MS. See, it can get smaller, how it gets bigger on the left eye. Okay. So that's a reaction. That tells me something has affected someone's left eye. So if someone comes and sees me and says, many years ago, my left eye was a bit blurry, but I didn't know what it was. And I examine it, I see this, I know there's an MS attack. That's where the examination is very useful, to look at certain changes in the exam that typically involve the central nervous system that is seen in MS. Here's another patient. So this patient is looking towards the right-hand side. And you can see, well, this eye towards the right-hand side. So the right eye moves right, there's no problem. But look at this eye, it doesn't move all the way in. And so the patient can report double vision. So these are, just to give you examples of how I know when I examine patient, looking at the eye movements, I look at the strength, I look at the reflexes, and I can look at the sensation and walking. I can identify who's been affected by MS or not by looking at these findings. And the exam is quite important because many of us have different symptoms, but I like to confirm that this is truly MS related by the exam. Because, gosh, people can have strokes, people can have migraines, people can have seizures, they can have different things that can mimic the same things. So that's why the examination is so important as well for following MS patients. You've probably seen the eyes, when doctors look into your eye and what we're looking behind the eye. This is what I'm looking for. So if someone has loss of vision, this sort of here is wrong. This is blurry. It's almost like a little volcano. It's like a little mountain sticking out towards me. That means this eye is inflamed. And if I leave it alone long enough, I will see this paleness. When I see this paleness, I know that someone has had a previous attack. This just shows you how examination is so important to us to tell me what's going on in patients. Now that's fine. So I told you about the typical story of patients describing an attack. I tell you about the examination findings that are important for me to confirm my clinical suspicion. But the big thing that has really changed our management of MS has been with the MRI. Now, I can tell you back in the 1990s, we didn't have many treatments. I remember when I was training, and if I felt that someone had first set of MS symptoms, we always say, don't tell the patients, because as soon as you tell them, they become very scared. Insurance stops covering. Like there's a huge implication for their lifestyle in the future. And we said we have to wait for multiple attacks before we make the diagnosis. And it was hard as a resident. When we were training and we saw someone young, I knew that in the future, it was going to be bad, potentially bad for them. Things have evolved so dramatically because now we know with our treatments, if you go and start the treatments fast and early, we can delay many of the things. In fact, almost give people a reasonable quality of life. And so we no longer wait, but we try to make the diagnosis earlier. And that's why the MRI has changed things so much. And you might have heard the term McDonald criteria. That revolutionized because basically, if someone has the first attack, I see the MRI changes, I use this McDonald criteria to make the diagnosis earlier, and that allows us to treat quicker. And that was a major purpose, impetus. We no longer say, just keep quiet, don't tell anyone, just wait for the second attack. As soon as they attack, we offer the patients treatment because we all know that if we treat them earlier, we actually delay the progression or the disability from MS patients. So that's why the McDonald criteria became such a major field change in our area. These are just different criteria that have been upgraded over the years. In fact, there's going to be another one that's going to be upgraded within the next few months. What do I mean by MRI changes? Let me take you to look at the brain. Let me show you what I'm looking at. Here's the brain, here's the right side, and here's the left side. So I'm looking from the bottom up, and I'm cutting the pieces as I go up to the brain. So the MRI allows me to look at how the brain appears. And you can see these white spots here, and you can see these white spots over here with my arrow, and some spots over here. These are changes that look like MS. Now, be very careful. Just looking at MRI, I cannot tell someone has MS just based on the MRI. People always focus on MRI as a diagnosis. MS is still based on the right story, the right exam, and the MRI helps me confirm. Because a lot of people, HIV, stroke, cancer can look like those as well, the MRI changes. So it has to be in the right context. So MRI just gives me a guideline to support my diagnosis. It's not the definitive thing. Just because you have MRI changes of MS doesn't mean you have MS at all. It has to be the right story and the right exam findings. Okay? Here's one. You can see the eyeballs here. This is the right eyeball, the left eyeball, and you can see this little white spot here that makes me suspicious of MS. And here's one of the spinal cord. I'm looking at the side of the brain. And so you can see the nose is here, the back of the head's here. Here's the spinal cord right down the middle. And you can see this white right here. These like little flame-like changes, that's a typical MS change. So these things with the right story, right exam, if I see this, it's quite clear to me, this is MS. Of course, there's a lot of people saying, what about Lyme disease? There's a lot of different things that can mimic it, but honestly, it's very straightforward. These appropriate story, appropriate exam, and these scan changes makes the diagnosis very straightforward for the most part. A lot of people try to say all these other different diagnoses. Not really. Like no one will tell me this is a cancer or Lyme disease. Like this is not a pattern. It's a very different presentation. So that's why just with a right story and exam and MRI, we're usually fairly confident in making the diagnosis. Sometimes we do things like lumbar puncture. We have to. That's taking a spinal fluid to look at the protein. But those are just again supportive. They're not the ones that it's not necessary to make the diagnosis. All right. So the implications that we are able to make the diagnosis after one attack and with the right MRI. So what about people that have never had any attacks? They get the MRI and they've got these changes. I said that's not MS. Don't rush into it. We have to watch because a lot of people can have those changes and they don't have MS yet or ever will. So that's why it's important. Now this is a slide. This is where I know it shocks a lot of people, but this is what we used to share all the time. And this was in a time when we did not have treatment. So when we did not have treatment, what often happened? Let me show you this third line. 50% of patients will become dependent on a device after 15 years. So if someone was diagnosed at, let's say, age 20, in the old days, I would say at age 35, there's a 50-50 chance that you might be using a cane or a walker. That is shocking for someone that's young, right? That's what our scare is. But this was in the context of when we had no treatment. When we have treatment, these numbers change dramatically. And so, in fact, the average the statement is usually about 7 to 10 years of delay. But I think the data is probably much more than that. We just don't have the long data yet. And without treatment, remember I told you about people that have initially the relapsing, remitting phase, the attack phase, they get better. But with time, they become secondary progressive, where they slowly progress on. Basically, after 25 years, 90% will become that without treatment. So that to someone that's age 20, I'd say age 45, you will likely be progressive patient at that time. It was quite hard thing to recognize, and it means a lot to people's lives. And that's why you can see a lot of physicians, especially people who have been involved with MS for so long, we are always saying, if there's indication to go on treatment, treat. Because this is what I had to usually share with patients when I had no treatment. And I had to say, and you try to always put a positive spin on things, but the reality from all this data was that they often didn't do well. And so the treatments do make a big difference. Having said all that, we always have to be humbled. Strangely enough, about 10%, if you look at this last line, 10% remain benign. What that means is that these are people that have relapsing remitting disease, right? They have the attacks, but they do not become disabled. They don't progress. And I do not know why. And we can, there's been a lot of exploration, like we look at the MRI and so forth, we cannot predict. So, and to give you a story, I work at Sunnybrook, as you know, and I work at the Veterans Affairs wing, like all the folks from World War I, World War II, and so forth. And sometimes we'll get consulted because they get headaches, and we do the MRI. And lo and behold, the MRI looks classically like MS. I go and speak to the veteran, and he goes, yeah, I remember I was in the trenches, and I lost vision for a few weeks in one eye. There was no doctors then. We were in the middle of the war. It got better. And so they would give me the story of a typical MS patient. I examine them, and they've got this pale disc. They clearly have MS, but they're not disabled from the MS. I did the MRI for another reason. And so about 10% can be in that category. But then, if I take it at all face value, if I was a betting man, all patients who have the disease, 90% will slowly become disabled without treatment. Only 10% will not. But that is an area that, I'm happy when someone is benign because they're not disabled. I don't have to treat them at all. But it's a small percentage still. Okay? Now, the whole phase of MS has changed. Like, this is a whole slew of drugs. Now, I'm going to give you a bunch of drugs. I'm not so interested in going through the mechanisms. That's not that relevant here. I will just give you a feel of how things have changed. The first treatments got published in 1993, and gosh, we have really a huge progression of different treatments, from very easy, gentle therapies that what we had before, all the way to much more aggressive treatments that we have now. And it's very encouraging. It's a huge slew of drugs, and it has changed the landscape of how I deal with MS patients. Now, I'm just going to go through a few slides because I think most of you may have experienced some of these drugs here. So the first drug that made, like, I graduated in medical school in 1993. This was the first drug. And so let me show you how we look at this data. Here is the people that are on placebo, and these are people on our treatment arm. Let me try to explain a little bit here. So throughout the centuries of the known MS, there have been so many reports on people saying, I found a treatment. Back in the 1920s, 1950s, 1960s, people will try different treatments, and they said they got better. But remember I told you about MS, where when you have relapsing remitting disease, some people have attacks, and they got better on their own without us doing anything. And if they happen to be exposed to certain treatment, they thought it was a treatment, they got better, they say this was a treatment. So it's very easy for people to say, well, I found a treatment that works. But as you know, this disease is so hard. The only way you can do a proven treatment is the following. These were the first, what we call multi-centered, double-blinded, placebo-controlled trials. So what it means is the following. You come to me, and I will say, let's give you a treatment. So the treatment could be placebo, treatment, and you won't know what it is. I will not know what it is. It has to be someone in another country looking at the data, because there's so much placebo. There's so much like I want the treatment to work, so I want to have something that I claim that will work, but we know that's very faulty. So people said, oh, I went to church on Sunday, and I kept on going to church and I got better. So that was the answer. That happens, right? Or I drank this certain juice, and I got better after a while. It's very prone. So unless you actually were exposed to something placebo or the treatment, it's blinded, no one knows, and only someone from another country says, wow, people on placebo did this. This is the number of attacks they had. People on treatment arm got this. And this had to be done, like this is a couple hundred patients. This took a long time to enroll around the world. And when people saw the first data, most of us said, is this real? This is like amazing. We actually have something proven. And it required multiple trials to prove this fact. But yes, this drug worked. This is the interferon, the old drug, the rebirth, the beta seron, the old drugs, that this was what the data was from. But most importantly, so just because you reduce attacks, that's great. That's, don't have to go to the hospital for steroids, that's great. But can we delay the disability? I told you, right? In 15 years, basically 50% of patients are going to require some aid. Can I change that? Can I delay that? That's ultimately the most important issue. This is what this trial was trying to show. Here is a 2-year trial. And what they did was the following. So here's the placebo arm, the red. This is people on no drug. This is the likelihood they progressed on after 2 years. This is the treatment arm. When they saw this, people were like, my gosh, we actually are making people less disabled. In fact, they stopped the trial early on because it's no longer ethical to keep on going on the trial. Now, theoretically, what I like to do is do a trial of 15 years, long-term trial, to see the difference between placebo and the treatment arm, to show the real difference. But that will never be done. How can you? It's like, it's unethical. The other example, let's say we all know penicillin is good for pneumonia. And let's go and expose people to placebo and the other people to penicillin to see they will treat the pneumonia. Too many people will die, and that's not ethical. So that's what happened here. They felt after 2 years, the results were so dramatically different, we have to stop the trial. And this has been so that you will see that most MS trials are about 2-year duration, and then they will see what the data is like, and they will report the results. Not only did we have less attacks, people were becoming less disabled. Here's the MRI. Here's the MRI lesions. With time, as you can see, over a 2-year period of 24 months, you have more and more lesions, and the green arrow here is people on treatment arm. People had less lesions or less active lesions. So these are just the simple initial trials that were done. And when it first came out, a lot of people with disbelief. But it became clear that we were supposed to give this drug. I can tell you even, like, for example, that in England, for example, they have a socialized medical care like us. They were very unconvinced. Like, these drugs are like $20,000 a year. You can see how much, the government's going to put out. In that country, they did the trial. Initially, they didn't believe it, but repeated trials showed the same thing. And then they said, look at the people. If you go to a nursing home because you become disabled, how much does that cost? Or you are able to keep on working, how much do you contribute to society? After several years, they said there was a big difference. People who are on treatment, even though it's $20,000 a year, they can still be able to work, stay at home, be productive. And so finally, they all jumped over. So right now, basically almost every country in our earth, basically, if they have MS, they will get access to these treatments because it clearly makes a big difference in their quality of life and the outcomes. So here's interferon. You probably remember this one. It gets red marks. This is all. We almost never give this drug anymore. This is an old drug, right? But these are the marks we see. And then you heard about this one. Now this one is still holding on. Glatiramer acetate, otherwise known as Copaxone, now known as Glatec because it's genericized now. These are the new drugs here. And this is what happens when you give a lot of injections. You get this little lipoatrophy. It's almost like people with insulin. They get this marking. That's the major side effects of these drugs. But they all basically are showing the same effect. They were mild, not dramatic effects, but they clearly made a difference on the MRI, number of attacks, and people that are slowly becoming disabled, we delayed them. So that's just to give you the historical feature of these drugs here. The big one, I guess, the era of change was something called Tysabri. So that's great. I showed you some of the easy drugs. Then this powerful drug came into play. So remember I told you the disease was due to these bad lymphocytes. These cells are supposed to protect us against infections, but they've gone rogue and they're attacking the nerves by mistake. So here's the picture of these. These are the, let me try to get over here. These are the cells that are supposed to protect us. But somehow these are the cells that are culprits that's attacking our nerves by mistake. This drug was created a blockage. So this drug doesn't go through into the brain. That's how this drug was developed in animal models. And lo and behold, this drug was dramatic. We in the other drug, we talked about like a 30% reduction of attacks. This drug, we talked about 60 to 70, 80% reduction of attacks. I was at this trial. We were involved in the trial. I remember we were attending it. Like people were crying. The physicians were crying because they've been involved in this area for so long. To see a drug like this is almost like as effective as for against pneumonia. This is dramatic. So there was so much excitement. But then the issue came up. This drug is so good at protecting your immune system. It protects it too much. It puts you at risk for bad infections. And this bad infection is known as, this is the one that became famous, was known as PML. This is a infection you get in HIV patients, where HIV, as you know, is due to a reduced immune system. The drug almost artificially induces like an HIV state, where it makes you at risk for these brain infections, and it's fatal. So now you say, oh, we have drugs that are not so effective, but they're fairly safe. Now we have drugs that are really effective, they can really reduce attacks, but they have risk. And so it's a balancing game. So now we'll see a bunch of drugs that are trying to fit in the middle somewhere that can be good at controlling a disease, but not at putting it at risk. Now, I'm just making it simplified. We're actually pretty confident in how we treat the patients now. I still use this drug for people that have really very severe disease that can't be controlled. And I still put them like, this is a risk we have to take, because if you don't take the drug, if you keep on progressing on, well, that's no good either. So most patients say, I don't care about the risk. So that's why there's always a risk balancing, and that's why we have to choose the right drug for the different patients. Over the years, we had the first oral medication known as fingolimod, okay, otherwise known as, when it first came out, was with a Novartis agent at that time. But the oral drugs are great. They're easy to take because no longer are they injections like the other ones, but they all have risk as well. And here, for example, the treatment, let me try to get the arm here. They compare this drug with interferon, and the oral drug is more effective. So fingolimod would be, otherwise known as Gilenya, is going to be a second-line agent that can be used. But again, it's effective. But look at this. I circled this. They were deaths. Where were they from? not from the infection of PML, but from herpes or hepatitis infections. And that's why you can see some people say you must get vaccinations before you go on certain treatments, because certain infections that to you and I will make us sick, but we still really recover. If you're on these drugs, you can actually die from them. So that's why, again, you can see it's not so easy. It's a bit of a tricky situation where if we give you a very strong drug, they will work, but we don't want to give it so strong that you die from other infections, or we do vaccinations to protect you against those infections. So that's why it's a bit of a balancing game when we're approaching patients. Tecfidera or dimethyl fumarate, the old name was BG12, is another oral drug we still use these days, and probably a lot of people are still on. Again, I'm not going to go through that. It all shows the same thing. These are what we call still safer, a little bit more aggressive than the interferons and the Copaxone, the glutamate acetate I told you about, but a little bit more effective. This one, as people will know, that you can often get some flushing and some stomach problems initially, but it usually goes away. It does have some risk of the brain infection, but not very high, and we can monitor that. This one was made famous in Toronto. It was some of your patients of Dr. O'Connor. Paul O'Connor, he was one of the major leaders in this development of this drug. It was an oral medication. We were involved in the clinical trial where basically it's a very easy oral drug, but the risk is that it can cause some hair thinning, and it can cause sometimes a problem with having children, so you have to be off the drug. So these are all gentle drugs. Some of you might be around or been exposed to alemtuzumab. It's more of a historical drug. This was a drug that had multiple effects on suppressing the different parts of your immune system, but it was great because you only had to treat for a short time. And then after you treat for a short time, you can wait, and you can wait for a couple of years before you even have to retreat. So that was very favorable, because as opposed to the other drugs, you have to go ongoing treatment. This, you treat for 1 or 2 years, then you can wait, and you're going to be good. We don't use it so much because there's some risk with this drug. And the risk, like I listed out here, you can have blood infection, thyroid, and kidney failure, and all this. Suffice it to say, it was a great drug because it's clearly very effective at that time. But nowadays, we have moved over. We've moved on to other drugs. We don't often prescribe this drug anymore, but it's available as well. Here's a graph that's trying to depict. Let me show you. It's a bit of a complicated graph right here. The bottom line is safety. So the more you go here, the more safe it is. The more you go to the X, the 0 point, is more unsafe. But here's the effectiveness. So drugs that are in this area are very effective, but not very safe. Drugs that are here are very safe, but not effective. So ideally, you want to have a drug right here. Drugs are very safe and very effective. And so that's sort of our golden grail. Now we are moving close. Some of the drugs are slowly moving in this area, and which has been a great area where basically drugs are quite effective and fairly safe. But we don't have one that's clearly right up this spot here right now. Okay? I think what has been changed in my life in the past 10 years in treating the drug, it's been one that's known as ocrelizumab or Ocrevus. This is an every 6-month infusion. These drugs have they have a different mechanism called anti-CD20. So they attack a certain cell type that's involved in attacking in MS patients. And so what it does is that, here's the placebo, the treatment arm. These are relapse rate reduction. These drugs, and after a long time of treatment, has shown to be persistently safe and effective for the most part. So I just want to show you the drug that has been very effective. So this is ocrelizumab. People have heard of this right now. And the new one that we were involved with was called Kesimpta or ofatumumab. Okay, these are the same sister drugs. So this one is every month injection. The other one is every 6 months. But they're all under the same category of anti-CD20 therapies. These are all what we call high effective drugs. For me, this has changed the landscape of MS treatments because when you go on these strong drugs, they are really much more effective. They are a bit more risky, clearly more risky than the interferons, but the risk is not that bad. Like compared to, I showed you about the natuzumab, the Tysabri, that one is much higher risk. This one is very close to it. So that's why this has changed a lot in terms of our treatment. And I'll show you how the data, how these drugs have really shown delay of disease progression. That is the most encouraging thing that we have seen in these patients. So here, right now in Canada, we have these drugs here. This is called first line. These are the gentle, easy line therapy, like interferons, glutamate acetate, people on teriflunomide, BG12. And this is the second line. And it's a lot overall. Now, just to put in here, third line stem cell. Everyone asks me about stem cell therapy, okay? So stem cell therapy is the one that is very effective, but the most risky. Like where people, basically, you're risking dying on them, right? And we don't readily available, not in Canada, except in Ottawa. There's certain sites that are doing it, that are expertise in dealing with treatments. We will only use those therapies when you clearly have failed the other treatments. And what do I mean by failure? You go on treatment, you keep on having attacks, your MRIs keep on being a lot of active lesions. That's when I'll use the highly aggressive therapy. Right? It's really rare that we need to use that approach. Now, some people ask me about the stem cell. Again, that's a whole topic on its own, right? There's a lot of media, a lot of privatized industries. This is not that type of stem cell. This is the real dangerous stuff. This is the stem cell therapy, for example, that we give to people with leukemia. These are really risky therapies. That's why there's such a high risk of, potentially dying from them. So you have to be very careful with that. This one, I just wanted to tell you, there's something uniquely Canadian. Believe it or not, I give you all these therapies, but there's another drug called minocycline. Minocycline is like the tetracycline. Minocycline is given for acne. And in fact, I just shared this before because this is a Canadian story. This was people that have early onset. What do we know? The first attack, we know as CIS. I haven't talked about CIS or clinically isolated syndrome. These are early forms of MS. We know how all our drugs are around, $20,000, $10,000, $40,000 a year. Some of them are $80,000 a year. They're very expensive. This is a cheap antibiotic. And so they actually did a trial because it worked in animal models and people with early disease. We were all involved in the Canadian centers, and lo and behold, this drug worked. The animal models proved it worked. So if you want to have something that is the cheapest, that's just antibiotic, this is an option. And this used to be important for countries where you couldn't afford any of these expensive drugs. And so we can say you can use antibiotics. But right now, almost every country is having access to the drugs. They won't use this. It's just unique because it's a Canadian story, the Canadian clinics that were involved with it. And it got published in the New England Journal of Medicine. Like that's the most prestigious journal. But this actually can probably work, but it's just very mild in its effect. I think the biggest thing has been right now, I've been talking about relapsing remitting disease, people with attacks get better. We now have treatments for primary progressive. That's the one where people slowly get worse with time. Gosh, when this trial was started, none of us really believed it. It's like we were so disappointed with so many trials over the years, but this trial actually did show a difference. And so this one for primary progressive disease, and even, the secondary progressive where you have attacks and slowly with time you slowly progress on, this drug called siponimod also work. These are just big treatments that we couldn't believe actually will work. I guess we get cynical after many years of trials that were always negative. Now, the way these drugs work is for people that are clearly progressing on with active MRIs, where the lesions on the scans are still very active. And by that, I mean either what we know as new lesions, or when we give the dye, there's actually inflammation going on. That's where these drugs work. They don't have relapses, but what it does show is that people do become disabled slower. That's the idea with these drugs. And so that's where it's been quite exciting for us. I got some slides, I don't want to delay too much. This one area, let me show you this. This is probably more useful for information for you. Let me show you, how I said why we are always pushing for drugs early on when we diagnose. Even though there's 10% of patients can be benign, 90% we often don't know that they can be more aggressive disease. So some people say, give me the drug right away. So I'll call them early starters, right? Some people say, I want to wait and see and delay. So we can call them late starters. So here, let me show you this graph here. This is the time of people that are still maintaining function. So the people that are higher here, are people that are doing better. People have down here, they've progressed on. They're getting worse and worse. This is what happened when they looked at people that started treatment early on. They all still progressed. You can see this dark blue line, but compare that to the white one. This is people who delayed it for 5 years. So that's the idea. So that's why when you see your physician, they say, don't delay. Because as a rule, because I can't predict what's going to happen with any individual patient, people who delay treatments, they become progressive much more earlier on than people that are on treatment. And that's the whole impetus for why we are pushing the drug. For me, it's like I'm going back to when I first graduated. I didn't have anything at all, and I just saw them slowly get worse. Now, when I see them, I actually do believe that if I start the treatment early on, most of them will keep on being fairly functional as long as they don't keep on delaying the drug. We don't have a cure. Are there people that still will progress on despite what I do? They do, but they do progress on slower. That's my own sense of what I'm seeing right now. The whole other area of controversy, and that's probably where I'd like to end so people understand what's going on, is the following. I told you it's a fine risk, right? I've got these strong treatments, but I have these potential side effects. And then I have these ones that are gentle and weak, and they're safe. So is it good enough for which patients? It's sort of hard to know. This is a whole concept between something called escalation, start low and go slow, or highly effective treatment right away. So the ones I told you about, my ofatumumab, my Ocrevus, my Tysabri, those are my strong ones. And the easy ones, for example, with teriflunomide, with Copaxone or interferons. That's where we use these ones. The general thinking has always been, in order to avoid doing harm to patients, let's go for a gentle therapy first. And if they do okay, we follow them closely. We leave them on a slow, gentle therapy. But if someone goes on a slow, gentle therapy, or even early on, I think the disease is very active, we push for the high effective treatment right away, because we know that the stronger we go, the better outcomes it is. It's a balance. Not everybody is the right category. That's where your relationship with your neurologist is so important. You discuss what risk you're willing to take, and how much risk, and like what your disease, how active it is. We have clues. If someone early diagnosis, very heavy MRI burden of disease, many attacks early on, I tend to go right away to strong therapies. But if someone has mild disease burden, maybe a gentle optic neuritis or something that's mild numbness, tingling, not really that badly effective, we might go for the early therapy. So it's an ongoing discussion, and this understanding is evolving with time. My understanding has always been this approach. For many, many years, I've done this. But over the past 5-10 years, for my early MS patients, I sometimes becomes very effective. I use high effective therapy early on because we have the treatments now. We didn't have it back then. Now, there are some people that have been on this gentle therapy and they've done well. 10, 20, 30 years, I've seen them. They have progressed, but not much. Why would I put them onto a strong therapy when I can make them very ill? So, it's a bit of like a balancing act, and we're still trying to understand the best ways. So when someone is so dogmatic, you must go on one or the other, there is a bit of an art of medicine. So you have to try to figure out what is the most fitting for certain patients as well. Here's the idea. So this particular graph is where this is the higher graph, the more disabled you are, and the lower graph is less disabled. This was people treated initially with the gentle therapies and aggressive therapies. So this is the group of patients where they had bad disease, and if we gave them gentle therapy, they didn't do as well. If we gave them strong therapy right away, they did better. They were less disabled. So this is all new data. These are all within the past few years only. We're slowly getting data. I think there will be a move towards more aggressive therapy. The biggest challenge, however, to use aggressive therapy is often the funding. Governments are very reluctant to pay for these expensive aggressive therapies. Fortunately, we are in Ontario. We have been granted that. We have now access to stronger therapy as long as we explain why. So that's over the past 2-3 years. We've been very thankful for our government's willing, the Ontario government, to do this. Not every province is doing that. And it's funny how the whole politics around different jurisdictions are allowed access to different drugs. I'm not going to, let's go with that. I've already talked about these ones there. I think we have about 7 minutes left. So I just want to touch COVID at MS. This was a big issue a couple of years ago. COVID is really not as bad as it is right now. The big issue was that during the pandemic, was COVID causing more MS issues? No. But what it was people on the strong therapies. Remember I told you about my aggressive, they're very powerful. What they were finding is that people were much more sicker. And so, the strong therapy like Ocrevus that I talked to you about, they were twice as likely to be in the ICU from COVID. And therefore, that's why we are always saying, if you go in strong therapies, get all your vaccinations done. That's the best way to protect it. And even when you get the vaccinations, this was a whole controversy for a while, where we see that even if you, let's say these were patients with, this is how much antibody, this is how much effectiveness your vaccine was against COVID. This was with the strong therapies. These were the basically gentle therapies. So you can see how much more effective the vaccines are. So all it meant was that even though you got the vaccine, it's not as effective, but it's probably better than nothing. So that was a big controversy now at the time with the COVID. Unfortunately, it's less of an issue. You know what? I'm not going to talk about symptomatic treatment too much, because I think the next speaker will probably do a much better job than myself. I will just tell you a little bit about this. People often ask me, so when you have attacks with MS, what do? We go to the hospital, we give steroids. So steroids basically will make you get better faster. But you see, steroids will only make you get better faster. It won't change your outcome. So even with anyone with MS attacks, if you don't take any therapy, you probably will get better by yourself. Will do nothing at all. So basically, it shortens the degree of deficits, but it's not a long-term therapy. So when I was a medical student and training in neurology, we gave steroids to try to get people better faster. It was only a short-term gain. Ultimately, it made no difference. And remember, when you give steroids, it has bad effects on your body, especially with bone breaking. Long-term use can cause diabetes, high blood pressure, skin changes. That's why, people say steroids are good. Not really. It's a short-term gain. Long-term, it really wasn't a very healthy thing. Our other drugs is what's important to try to treat MS patients. All right. So steroids are given. In my clinic, we've been doing for almost 30 years now. People used to have to come in the hospital to get IV. We don't bother. We just give oral. You can stay away from hospital, can take the treatment at home. It's much easier. So that's what we tend to do at Sunnybrook. So it's a bit of a tour de force. I hope I shared with you what the disease was, who gets it, what the typical symptoms are, and how we diagnose it, why it's important to diagnose. And then I went through all the different treatments that are currently being done and the controversies about the different approaches for the different treatments. I know I'm just touching a little bit on each area, and maybe there are a lot of questions, but at least I hope I give you a bit of understanding. But over the past 30 years I've done this is, our understanding of the pathology has evolved. The treatments have evolved as well. It's been amazing, right? I come from the first time when I was first dealing with disease where, I was with Dr. Trevor Gray. Some of you might remember from St. Michael's Hospital. When he was doing it, people saying, what are you doing this for? This is a very bad area. We have no treatments, nothing at all. He kept on believing in it. He started the clinic at St. Michael's. We started the treatments. And then when the treatments came up, this has evolved so dramatically. And it's become really, in our field, a rather exciting area. Now the next part, we want to cure, and we can stop the disease entirely. When I first started, I thought, that's a bit of a dream. I don't know. We have treatments for progressive disease. I couldn't believe that. And so, maybe this will come about. And the other aspect of it is, can we find things that can reverse or build myelin, build things, improve again? So there are trials. Yes, there are things called BTK inhibitors. That's a big whole area that we've been exploring right now, where we're trying to improve repair. We can see it happening in animal models. We just don't see it in humans yet, but that's a hope. And so it's come a long way over the time period, and maybe in the next 10 years, we can see another whole new chapter. But with that, I think I'll close, and that's been an hour, so we have half an hour for questions. Thank you.
Dr. Lee, we have a question from the chat.
Yes, please.
Actually, you have touched just very briefly at the end of the presentation. Question is from Thomas Richards, and he's asking, CRISPR technology treatment turned off the T cells in mice with induced MS, and the mice remyelinated the nerves and recovered movement. Question is, when will CRISPR treatment be available for people with MS?
So, yeah, I hinted at the end. It's very easy to treat mice with MS. All our treatments that I showed you were very positive with mice or different models, with animal models. But we haven't shared with you 95% of all the failures. So it's always easy to get mice treated. What often happens in these trials is that we will translate it to what we call phase 1 trials to say if it's safe, whatever product it is. And then we start doing to phase 2, then we try experimenting on human trials. Remember the trials with humans, though, it's what we call phase 3. It has to be a multi-centered, placebo-controlled, double-blinded trials. And we never say never to anything, right? Whenever there's a hope, we hope for a drug company who believes in that and willing to spend the money to do the trials. That's what we're doing all the time. So those trials we see in mice that works, we hope. That's all we can hope. When we do the animal and then the subsequent human trials that are positive, that'll be the biggest excitement. And so we can only keep our fingers crossed. When they work, you'll hear it in the news media.
Thank you.
Yes.
Personal experience. I won awards for not being sick all my life. I even use it in interviews. I'm never sick. So I get this fantastic government job, and they encourage everyone to go get a flu shot. I never had a flu shot. I take the flu shot. Within a month, I had optic neuritis. Is there any relation to the flu shot activating your immune system to attack your myelin?
That's a great question. Yeah, the issue that, the gentleman has always been very healthy. And then upon taking a flu shot, he became unwell and the first MS attacks. So I can respond to that in a theoretical manner to the evidence-based manner. Theoretically, that makes sense. Somehow, because that's how flu shots work, we activate your immune system to produce these protective things against this virus, the flu or COVID or whatever virus we have, right? And so when you rev up the immune system and you've got a deviant immune system that's attacking your nerves, you've revved it up. So that could be a bad thing. But then if you look at the epidemiology, so we've studied this quite a time, like we looked at large numbers of people with getting vaccines to they get really much worse MS, worse down the road. We have not seen that. But we've seen some increased numbers of relapses in small group of patients, but overall they didn't do worse. Then that's why that's an interesting question, because what if I went the other way? Let's say you don't do the flu shot, but you got the flu. Now you've revved up your immune system because of flu, and then you have more likelihood of having attacks as well. So you see, that's why that's a bit of a clinical equipoise. The discussions we have, so if someone asks me that question, I say, it does depend on how bad that virus is, I guess. If it's a common day flu, I can see the argument. Maybe you can avoid it if you don't want because you have bad experience. But let's say something bad like COVID, or let's say the SARS, many years ago, something bad, I would say that risk of that bad virus probably overrides it. But there's no right or wrong answer, right? It's a relative risk because we don't have the full data. But as a rule, because let's say you do the vaccine and everyone gets bad MS, it'll be easy shown in the data. We'll tell people not to get the vaccines at all. We have not seen that. We still see people, vaccines they generally did the same as anyone else.
I appreciate a doctor using common sense. Like my doctor, he was pushing the COVID shot for everybody. And I said, the flu shot gave me MS. I'm not going to take the COVID shot. He said, okay, never mind. Don't take the COVID shot.
Yeah. That's an individual decision. There's no right or wrong answer. We can only go by theoretical, like COVID for me, it was bad, right? It was a very, especially if you're on one of the strong therapies, then we say it's very risk, like twice likely of going to ICU from one of the drugs. That's pretty scary, right? And so that's why. young lady in front of you.
Okay, thank you, Dr. Lee.
Sure.
I just want to ask you, how does anxiety exacerbate MS flare-ups, and what is the best way to deal with it?
Anxiety makes anything worse, no matter what. You have headaches, it gets worse. It makes everything worse. It makes the symptoms worse all the time, right? And but anxiety itself doesn't make the MS disease worse itself. Let me try to explain that. So a lot of people say, I've been through a lot of trauma. I lost my job and all the rest there. And could that make my MS worse? Stress in life can make my MS worse or not. They actually looked at that. You know what they did? They followed a group of patients that they lost their wives, spouses, they lost their children in a car accident, or had breakups, divorce. These are among the human experience, among the worst stresses we can think of life. They do not see any MS worsening from that. The MRIs do not act more active. They didn't have more attacks. But they make symptoms worse, no matter what, right? Anxiety, you're not sleeping as well. You whatever symptoms you probably would have ignored before, when you're anxious, you think of it much more. And so the speaker often will probably tell you how to deal with anxiety. There's different approaches, right? All the way from, the medications or behavioral changes. Dealing with anxiety it's not just an easy fix. And some people don't respond to drugs. Some people respond to other techniques as well. There's not always one right way. So dealing with whichever way through your family doctor, and sometimes the psychiatrist have to be involved, is probably the best way. Yeah. Sure.
My question is, for someone who is in their 30s, they've just been diagnosed, and their consideration of starting a family. They're on the process of one of the meds, let's say. What are the prognosis of even considering having to start a family, and what is their outcome down the road?
That's a very practical question. So the issue is starting a family, someone newly diagnosed with MS. 30 years ago, the old days was don't have children, and it was bad for your disease. It was pretty devastating for young couples, right? No longer true. We have no evidence now having been pregnant or having children will make MS worse in any way. So we encourage it. Is that it's part of life. Please proceed on. The issue is that with drugs, very few drugs are actually safe for pregnancy at this point in time. So my strong therapies, for example, are not really safe. We have to be off the drug. But if, the one I told you about, glutamate acetate, Copaxone, that one is safe. That is safe trying to conceive, being pregnant, and even breastfeeding. So if I have someone that's very bad disease and I want them on something strong, but they want to start family right away, I'll go on this gentle therapy, right? That one drug is better than nothing. But if someone is, unstable, bad attacks, I tend to say maybe get control of the disease first, because we never can predict what can happen with pregnancy. So, but as a rule, the disease becomes less active in the second and third trimester. So, but it's only when the baby is born, the first 3 months, they have a higher rate of attack. So that's there are different variables that when we come to talk about that. Yeah, sure.
Dr. Lee, can you hear me?
Perfect.
Okay. Last seminar, Dr. Bruno, just like you at the very end, mentioned BTK inhibitors. Now, do they eliminate the disease or just slow it down? What does they do?
Again, these are science approaches. They have a very novel mechanism in that the unique targeting is on the repair mechanisms, besides modifying the immune response, causing the attacks. But they also seem to have a role in fostering repair, called the glial cell repair mechanism. And that's what's so exciting or unique about that property. I don't think it stops the disease at all, but I think it may help repair. I'm a bit cynical. We have 2 trials using BTK inhibitors. I have to say the most disappointing news just recently was in there's been a trial with early form of MS, relapsing remitting disease. The outcome measures were not that exciting. So I don't want to say negative things yet until I have all the results coming out from the progressive phase. But I'll be excited if it does show some more repair, but I don't know yet. Yeah.
I just would like closer. Yes. Hi. I just like you to expand a bit on the other drugs that you recommend, or instead of Lemtrada. My daughter has been on Lemtrada. She did 2 treatments, 2
Right.
years in a row, but that was about 6, 7 years ago. Now
Right.
she is stable, but her cognitive and her memories are really getting worse. So I'm not sure. Is there like other treatments that you said instead of Lemtrada?
I can't give you advice. You have to know the whole history, and it's something to discuss with your neurologist there. But the general concept is Lemtrada was one of the top drugs at that time. The issue has been the safety profile. And right now, because of the new drugs, the anti-CD20 therapies, if someone is still having active relapses or active MRI, we have other options.
That's what I really
Yeah.
wanted to know, if there's other options.
Yes.
This doesn't work.
Yeah.
Like going down
We do.
years down the road.
Yeah. And even, in fact, if someone asked me, what's the best drug, the most effective drug? Tysabri, the one, the risky one that causing the brain infection. That was it.
She nearly died. She did
Yeah.
it at the clinic, and then she was hives.
Yeah.
She did the second treatment. They had to rush her to the hospital. She was terribly allergic to it.
Yeah. We can try to sometimes use like stirrup things to try to avoid that from happening. But you're right. Everyone's very individual. But as a rule, Tysabri is quite effective that way.
Not for her.
Yeah.
Killed her. Okay. Thank you.
Dr. Lee, in Asia, it shows minimal people getting cancer, minimal people getting MS. So what do they have in their system that protects them from cancer and MS?
Oh, they have a lot of other diseases that they have to contend with. So I'm not so sure it's an interesting question though, because although MS is 1 in a million, there's probably a related condition that's become very popular now, known as neuromyelitis optica, NMOSD. And I only mention this because we used to diagnose many patients in Canada as MS when they were actually NMOSD. And so that's actually much more common there than us. And that one is a condition where you become blind and paralyzed very quickly. And the MS treatments don't work in those cases. We have to use other strong therapies to control that. It's just different things. I can't say their MS is much different. They just get it less frequently, but they can get bad disease as well, everyone. So
I won't ask for a blood transfusion then. Thank you.
no. Oh, you want to become Chinese and try?
I drink a lot of green tea. It helps.
Well, that may be, yeah.
Okay, there's a couple of
Sure.
things that I've been curious about for a long time. I'm a nurse, so I sort of pick up on stuff. But the geographical location of the person when they are having their flares. I was down in the United States, southern states, for quite a few years. And this is when I started having my optic neuritis, was starting to have numbness in my legs and everything. They did tests, but they didn't come up with anything. It was when I came up here that they did one test, said, wait a minute, we got to do more. And that's when they found it. And I mean, I had huge numbers of lesions. I think, down in the States, I think they were just thinking, oh, she's just getting old. I mean, I was mid-40s when I came back. That's not old. No. Anyway, it just seems to me that there is, because there's such a difference in the amount of diagnosed cases in those southern areas, do those doctors, neurologists down there just not even think about it?
That's a rather touchy medical political
I know, but I've
statement
been
you want me to
saying that
make.
for
But
years.
honestly, I think MS is such a common condition, I don't think there's a big disparity. Like people will even argue, you get access to imaging so much easier in those areas there, but the prevalence is slowly, seemingly going higher. We are diagnosing easier. And some people they don't show it on the initial scans. And that's the frustrating part initially. And sometimes I'm kicking myself, like some patients I followed over these, I didn't think it was. And there's been many times I've been humbled, and it really was MS. And I think we're still learning. Maybe there's other imaging modalities that are easier to make the diagnosis. I think if you were, let's say, in Africa and so forth, then they probably won't think of it. But not if you're in the developed countries. I think we generally are able to diagnose fairly easy.
Okay. And then there was this whole thing about endarterectomies.
Right.
Is there really any basis of truth in that? It's very, very risky. So, to me, why
this is more than 10 years ago, and what the liberation therapy is what you were alluding to. Although know the CCSVI, what they had found was that there were some blockages of the veins, and people were purporting to try to open up by putting stents. That is a very controversial area for a long time. And it caused a lot of, distrust, because people were saying that neurologists didn't want the cure for the disease because they were pushing for as a cure for the disease, and we're in bed with the pharmaceutical companies. And I can see all the concerns that were raised at that time. The truth of the matter is that, to answer your question, they finally finished off the trial, and it was negative, clearly negative. And it was hard because our major newspaper like CBC was pushing for it. David Suzuki was pushing for it. Like all those things were pushing for it. But they have not had retracted many of the statements, because when they looked at the final trial, in fact, the MRI actually got a little bit more activated from that. Now, I don't think it does harm. I just don't think it's that effective, unfortunately.
well, it's also very dangerous.
I
mean, for the side effects as far as stroke and heart attacks and all that sort of stuff.
Fortunately, we were involved with the, I was part of the panel that looked at how to find the safety of the complications. You usually get clots. It's not frequent, but it is there. And the big issue is that, I think the biggest side effect is people are paying money, and there's still these companies that, you can go to get these things done. If you're asking me, is there any evidence? Unfortunately, no.
My holy Dr. Zamboni in Italy, I think it was more of a placebo effect where people think they open up their artery and they miraculously get cured, but more a placebo effect because they just downgrade.
I wouldn't say that. It helped my daughter a lot. She went to Poland to do the CSPI. She came a walk, she came back walking.
The issue is that, the issue is that, the idea is that if you do it, then you can just keep on doing it and it stops the disease, right? And it hasn't. And so when we finally did the formal trial, they did worse than placebo or same. So that's the only way, right? That was very well timed, Ivan, to emphasize my point. That was no, I'm sorry. But no, it's hard, but you really need. How I emphasize the importance of these trials that be blinded, because people had so many stories. Like you see, the internet was so flooded, and we all believed it. In some ways, I wish it was done. It's true, because then it's so easy. It's so easy, but it hasn't. People progress on, and we're looking for something that really, really deals with the disease. It can slow it down much more.
Are you taking patients?
There's Sunnybrook. If there's local neurologists need help, then it's always open. Always open.
I have a question. How does a person start or get involved in the right program?
It's your neurologist.
It means in treating this disease.
Our daughter has been analyzed with MS, and we're not getting the proper treatment.
It's so hard. I apologize on behalf of the medical community. It's very hard to. I guess you have to always go to, like, firstly, the family physician that you trust, or some physician, healthcare professional you trust. There's ways of navigating, right? You can always get different opinions. You can always pursue. It has to be a relationship between yourself and the neurologist you feel comfortable with. So, and it's like anything else, right? How do you find someone if you've had bad interactions, you find someone else, so to speak, but you have to find someone that you feel that is being honest and try to treat it properly.
Does Sunnybrook have an entrance program?
Oh, my program is nothing fancy. That's what it is. It's basically, I've been running this program since 2000, right? So we've been around for 23, 24 years now. Essentially, because the volumes are high, the hospital made their requirement. If your local neurologist feels uncomfortable in managing disease, they make a referral. It will always be accepted. I don't stop. Now my numbers are high, but it's always open.
Thank you for your seminar.
A pleasure. And thank you for the MS family for allowing this to occur.
Do you know a Dr. Lee from Brampton?
Many Lees, but no, not that one. No. Yeah.
Just wanted to ask the connection with Sunnybrook and St. Michael's, because that's where my daughter's been attended, and she's had great service. Like, I can't.
Sure.
But I just wanted to know, is there that collaboration between the hospitals? Because this is what we need to see, is that there's a fortified support system across. And I know
Yeah.
Eagles can get in there. Sorry, I have to throw that in there.
That's great. I wish,
Necessarily good, but I'm just saying.
you should share that with the St. Michael's. They have like $60 million. They can try to share with my. Anyways, they have a very beautiful center. It's incredible. I've visited them. Many of the neurologists there are my students, were previously my students. So I've been around for a long time, but they're a very good bunch. They really do great. We don't collaborate because we have such huge numbers. Of course, we collaborate with research, and we know all the different ideas, like all the things I've shared with you. We all have similar ideas. We collaborate that way. And sometimes trials we collaborate, but for patient profile, they have so many neurologists there. We're so busy as it is. So they are very distinctive groups that way. But they do very well, right? So.
Do you believe in Chinese medicine over Western medicine? I did do Chinese medicine.
Sure.
It almost crippled me because they used all kinds of roots, and I wasn't able to walk. And I asked him, I can walk now. He said, good, it's working.
So I'll share a personal story for you. So I'm from South Africa, and we didn't have much medical care at that time. And my mom, every weekend, will make me drink these most bitter roots you can ever think of. My brother and I would have to have some candy so we won't throw up because it's so bad. And she was insistent that I have to take this Chinese medicine because it'll make me stronger. My biggest benefit of going to medical school was telling her, I'm no longer taking any of your medications right now. I'm a doctor now. So that's my bias. But, in medicine, we have to be humble, right? I can't say one is clearly worse than the other. I can only go by what I've been trained at. Is there good evidence that some of these therapies are benefit? If it was, we would have been able to prove it. We would definitely do it. It's easy. We feel safe. I just can't say that with all good conscience. I've done acupuncture. I was trained in that before. It was my research before. I just can't in good conscience say I can say this works. Definitely. It could. We just don't have the trials to support that. So I'm coming from this other end. But I hate those Chinese medicines. I see this stuff in China.
Thank you, Dr. Lee, for your time and your expertise today. Truly appreciate, and I would like to hand to you. We have made a long-term promise to Sunnybrook and to your MS clinic. So I'd like to present to you a check for $5,000 on behalf of my MS family.
Oh, my word. Wow, I wasn't expecting that. We had received some funding before, and that is something that I can say thank you. The funds will go to our clinic, basically, is to I have a nurse and administrative coordinator. And my hope is down the road to try to get some physio, like free physio. I know that's difficult, but we're just trying to stand afloat in our clinic, and this will just go towards that dream. So on behalf, thank you very much.
We want to be part of that physiotherapy that you want to set up. We want to be a major endorser of that. But as well as, I know you take a lot of notes, so We're just giving you another little gift here. Use it in best of health. But thank you so much.
Chinese
for-
medicine?
Made in Canada. So thank you so much, Dr. Lee.
Thank you very much, everyone. Thank you.
Appreciate it.
Business cards?
Hello again, everybody. Hopefully everybody had a chance to get your little treats there and fill up with some fluids. Anyways, we have, I wanted to share with you, we have some special guests here tonight or this afternoon. I don't see Bridget, but Bridget Duguay, she is, she's in the washroom, okay. Well, she's here representing the Toronto Rehabilitation. She's one of the main social workers. She's incredible. She's also a huge supporter of my MS family, and we've been working very closely. And here she is. Hi, Bridget. I was just introducing you and how wonderful of a person you are. So, did you want to come and say a couple words?
Oh, geez, okay.
Well, that's when you hear the truth, is when you're on the spot.
Hi, everybody. I know some people, so at least it's not, do I have to, I'm pretty loud. I'm Italian, okay. I'm Italian, so I'm pretty loud. So my name's Bridget. I'm a social worker at the Rumsey Outpatient Neuro MS program. I work there full time and I provide counseling and resource linking. We are a program that is specifically designed to provide rehab to individuals who are living with MS. So it's still surprising to me that a lot of people don't know about us, and we've been around, I've worked there now for 20 years. Part of my role, in addition to linking people to resources, is I facilitate a group called Living Well with MS, Self-Management, as well as we do a cognitive behavior therapy group to help people deal with their emotions. So my role is resources and helping coping, adjusting, and living with MS. So that's me in a nutshell. And I don't know if anyone has any questions. You want me to ask questions? Anyway, I'm glad to be here.
Thank you so much, Bridget. Next special guest that we have, other than Dr. Ismail, we have the CEO of West Park Foundation. As some of you know, we're very, very appreciative to be part of West Park, and we've given them our word that we're going to continue supporting them financially, because in turn they're helping people with multiple sclerosis. So I want to hand over the microphone to CEO Doug Earl.
Thank you. Thank you. And it's great to be here and to see all of you. And I was really intrigued in the conversation. So watch out, Dr. Ismail, they're ready for you. They'll be ready. But I did want to extend our thank you to you and all of your efforts, sharing information, raising funds. We've been the beneficiary of your work. We're just about to open a brand new hospital. Our inpatient unit that specializes in MS is in our complex continuing care program is very ready, thanks to your help in part. As well, some of the research that Dr. Ismail and Dr. Boulias are undertaking to help improve the delivery of our spasticity treatments for MS patients is being funded by your support. So we truly appreciate the partnership that we've had and look forward to continuing that. And I know I've been asked a few times today already. We are just about ready to begin our tours again. Our patients are moving in Sunday, April 14th. And after that, we'll be organizing a tour for your organization to come visit, see our new facilities, the absolute amazing complex care unit, and all of our outpatient programs, the new spasticity clinic on the second floor of our outpatient wing. We have currently 6 assessment rooms. On that second floor, there are 18. So we're very excited. We've hired about 250 new people We've got about 200 more to go to be able to deliver all of the services that this new building in expanding our capacity enables. So we look forward to having you very shortly in the spring to show off what you in part have helped make possible. So thank you.
So now I'd like to introduce, and I know some of our members here have already have the services of Dr. Ismail. I just want to introduce everybody to Dr. Ismail from West Park, MS capacity.
There are enough in the room that know Phil Donahue. Yes. I can't stand standing behind the podium, so I'm gonna move as much as this microphone will allow me to move. To make sure you're all awake, because this is a long afternoon for you guys, and I commend you. I was reminding Dr. Lee that I was his resident back when I was and he looks younger than me, I know, but back when I was in my second year of training. So that would have been, I'm going to guess it was probably 2000 or 2001, where I spent 3 months on neurology service at Sunnybrook, and he was relatively new to staff then. I think he'd been around for a couple of years at that time, so I learned a lot from him. His was a very high-powered scientific talk. Mine will weave in as much science as you want me to weave in. I'll cite you resources. But you know, in preparation for this talk, I was looking at how rehabilitation for MS patients has changed since I studied for my Royal College exams back in 2003. And there's not much that's new, but that's not a bad thing. It means that things have been done right for a really long time. That's the way I sort of interpret it. So you can ask me about that as well. I plan not to speak for an hour. I want you to interrupt me along the way. We won't save questions till the end. Ask them along the way, and we'll get through whatever I need to get through to show you. The focus of my talk is going to be spasticity, and we'll speak about that. But before I meet my MS family, I want you to meet my family. So this is a bit of filler. That's can we get the lights? Is that okay? So my wife's really big on pictures. So this is the four of us in Spain last summer. That's Dad, the only one looking tired. That's my lovely wife, Gina. Gina's a family doctor, actually. And Gina doesn't have a family practice, but she works now out of Baycrest. So many of you or your family members may encounter her if you see her at Baycrest, because she works on the complex continuing care side. In all of her wisdom, despite everything that's going on in my life right now, and I'm going to give you a snippet of the last 12 to 15 hours, she's decided we're going to India and we leave next Thursday. We're going for 2 weeks. So my job after this is to go home and start packing, because she and I haven't gotten on that yet. This is my daughter, Inaya. You'll see another picture of her, and there's my son, Kyan. So Inaya's 14 and Kyan's 12. So here they are, still in Spain last summer, and they allowed me to put this picture up. I took their permission. We're at dinner, and it's near the end of the trip in Barcelona. And this young lady, of course, 14, thinks she's 19. Yeah. You know how that goes, right? I used to have hair on my head before I met her and Gina. Last night, I was her Uber driver because she was out with her girlfriend there, Alexis, and 15 other classmates to celebrate someone's birthday. So I rolled in with her at about 11:30 at night because she hailed the Uber at about 11 p.m. Prior to that, though, she's a big basketball and volleyball player. So that was the end of a basketball season, and yeah. But so there's Kyan in there. Bright little guy. He skipped a grade. So these guys are all 13, and he just turned 12 at the end of January. And he said to me last weekend, you know, I know we're busy. We're trying to get ready to go away on this big trip over March break. But, you know, I told my friends that they'd all come over and spend the night in honor of my birthday. When are we going to do this? So that happened last night. So last night, all these clowns, all classmates of his, they all play basketball together, showed up at 6 p.m. Bunch of 13-year-olds, him being 12. We took him out to dinner. Here's the proof. That's them at the dinner table. And then they proceeded to stay up until 4:30 in the morning, playing video games in the basement. Not a word of a lie. I walked down there at 3:45 in the morning and said, "That's it, lights out, you're going to sleep." They were laughing until 4:30 in the morning, and at 7 this morning, yep, my son, my offspring, woke them all up. So at 8 o'clock, we were making pancakes for them. They all left by 10. And at 11 this morning, that was kind. At 11 this morning at Taekwondo, was actually crying this afternoon before I left because he had a guitar lesson, which he does online. And I'm here and I'm still standing and I have a pulse. So that's just the last 12 hours of my life. So that's my family, okay? Well, might as well be. The amount I use my hands when I talk, I might as well be. What's that?
Did the liquor bottles get marked?
Exactly. So now that you have a glimpse into my family, and I hope that's broken the ice, I want you to share your stories with me as we move forward through the slides I want to take you forward through. So these are the grounds at West Park. Now, Doug, I don't know if you'd ever seen West Park in this state. So I've been at West Park. I'll finish 20 years at West Park at the end of June. And when I first came to West Park, this is exactly what the springtime looked like on our grounds. West Park is known for its respiratory rehabilitation program. 100 years ago, if you developed tuberculosis, they brought you to the grounds at West Park, wheeled you outside to breathe the fresh air because we thought that was the way you cured TB. Of course, patients did pass away. But it's a big respiratory rehabilitation hospital. I've, like I said, been there for 20 years, and I'm a physiatrist. So my specialty is physical medicine and rehabilitation. I'm on the neurological rehabilitation side of that equation. So I deal with patients with brain injury, stroke, spinal cord injury, MS, and adult cerebral palsy. So once you transition to adulthood with cerebral palsy, you come and see someone like me. But this is what the grounds used to look like. Not anymore. As Doug was describing to you, they built a fabulous new building, 6 stories high, Doug? Yeah, it's about 720,000 square feet. We're going from about 310,000 square feet to 720,000 square feet. It's a glorious place to be for patients. It's absolutely breathtaking. And those cherry blossoms I was showing you used to live right about there. But anyway, the grounds are going to be just spectacular when everything's done. I welcome you to come and visit. If you're not a patient there, you don't have to bring someone there, and hopefully you don't. Just come and visit. So what I hope to do over the next little while is understand what MS does to the central nervous system. And you've got it from a world-leading expert in Dr. Lee, but I'll give it to you at a very high level. We'll review the role of therapy in multiple sclerosis and when you should seek therapies. Now, I've cited a physiotherapist here, but it's therapy across the board. We'll review the current evidence around various MS symptoms and various management strategies. And then we'll finally spend a lot of time understanding MS-related spasticity and various treatment options. That's really going to be the meat and potatoes of what I'm going to speak to you about. So we all know that MS is chronic. We all know that it's, at least we feel it is, immune-mediated. It affects the central nervous system. I've heard you ask, I was back there for 20 minutes listening to the questions, and I was in awe. You're all highly educated about this process for one reason or another, whether it affects you personally or it affects a family member or a loved one. You know about relapses. You know about, also known as exacerbations. You know about remissions based on the type of MS that you have, and the variable progression of disability over time. In addition to relapsing forms of MS, there's a small subset of people that have a disease course that is progressive from the onset, called primary progressive. And did Dr. Lee cite you a number in that regard in terms of percentage of patients who are diagnosed from outset and sort of their course over time is this in terms of function? Did you see any numbers? It doesn't make up the majority. I'm going to put that number probably less than about 15% in terms of those that develop primary progressive. Repeated inflammatory attacks on the central nervous system cause damage to myelin. I heard some great questions about myelin. Remyelination is happening when you have rest or recovery from this situation, and that's when you have some improvement in your function. MS symptoms are highly variable. Is there anyone in the room that can attest to that? We're going to talk about that. Some of them include, and this is not an exhaustive list by any stretch of the imagination, fatigue, mood, cognitive changes later on in the game, problems with vision, as I've heard, sensory loss, but more importantly, sensory-related pain, neuropathic pain, problems within coordination, which I see a lot of, difficulties with walking or impaired ambulation, and of course, elimination dysfunction, pointing there more to bladder issues than bowel. That statement goes without saying. The cause of MS is not known, but current research points to the interaction of genetic, lifestyle, and environmental factors. And did Dr. Lee, and I missed it, did he point to or shed any more light on causes? Did he touch on that at all? Feel free to speak. What did he talk about?
Environment, like you mentioned about the genetics.
So still a combination of.
Yeah.
So the role of therapy in multiple sclerosis care. Therapy obviously plays an integral role. And is there anyone here who has experienced that personally or on behalf of a loved one? Do you rely heavily on your therapists?
I did when I was getting the therapy, but they first is not doing that really anymore. So, yeah, but it was a long drive too.
Okay. So I want to hear more about that because funding for these sorts of things, and I saw you provide Dr. Lee with funds to sort of bolster perhaps physiotherapy at the Sunnybrook site. In our spasticity program, we have a full-time physiotherapist working with our program, not exclusively for the management of spasticity. I probably shouldn't say that because this is going to be on YouTube, but if you have MS and you even have a mild form of spasticity, we're not going to say no to seeing you, period, full stop, end. You're going to come and see us, and if you need therapy, we'll provide it. Now, someone's here from the Rumsey site of TRI. What I didn't show you when I showed you the picture of that massive new building. Not only are we moving into that building on April 15th, that's when the lights officially go on, but we're amalgamating with UHN, which is TRI, and will be West Park. So there's 100 balls in the air right now that we're all juggling. That's a big merger, but part of our program is definitively physiotherapy, a lot of occupational therapy. We have a clinic coordinator, we have a clinic nurse, and I don't have a picture of them up here, but they are an integral part of everything that we do at West Park. So when you're seeking the intervention of a therapist, points to consider: time of diagnosis. So right when you're diagnosed, I think as good a job that MS clinics do to educate you about here's what the course ahead may look like. There's even more time that can be taken by a therapist who specializes in the area to explain what the highs and the lows may be, what they may look like, and what the road ahead looks like with respect to physiotherapy. So if you have someone who's newly diagnosed, seek the advice and guidance of a therapist, whether it's an occupational therapist, physiotherapist, or otherwise. Then we talk about during and after relapses. When you've had a relapse and you've come out of the acute care situation and you're trying to integrate back into your life, back into society, even if you were out of commission, so to speak, for a handful of days, physiotherapist is going to be very integral, or an occupational therapist or a combination thereof, in trying to get you back to your previous level of function. Now, I fully realize that therapies alone are not going to get you there. I'm not going to talk about the medication side of the house because you've had that exhaustive lecture and detailed lecture by Dr. Lee. So it's medications along with a therapist who knows in detail what your level of function was before you went in with that issue, and trying to get you back to that, whether it be with exercises, equipment, or a combination thereof. Then you get into situations where if you have relapsing remitting type, you're stable, and you could be stable for an undefined period of time, could be years. But during that time, for all of us, whether you have multiple sclerosis or not, exercise is key. And many may forget that. So your physiotherapist or your occupational therapist or a therapist of some sort is good to check in with. Here, the recommendation is every 3 to 6 months. And this source is a 2018 source that was put out by a physiotherapist, I believe American-based. But check in with a physiotherapist for the purposes of motivating you providing you with new exercises that you can do at home, making suggestions as to equipment that you might be able to utilize in a smaller space if your home is not conducive to having large amounts of exercise equipment. Almost think of it as utilizing a personal trainer when you're feeling good, is sort of what this is making reference to. During periods of progression. So again, here, if disease process is sort of taking you down a slope in terms of declining function, a therapist, I would say here more an occupational therapist than a physiotherapist, may be very good in assessing your home environment or your living environment, wherever it may be, and also making solid recommendations as to how you can remain safe in that environment, what equipment needs you may require, the cost of those needs, funding sources for those needs if required, and how that equipment can adapt to keep you in your current sort of living situation. Okay. And then when the disease becomes more advanced, again, occupational therapist more than physiotherapist will help to assess you for adaptive equipment, continued emphasis on upper extremity strengthening. Why? I'll tell you experientially that I think lower extremities are first impacted before upper extremities, though that's not the case across the board. And I don't have any statistics nor research to back that up. I'm just telling you about 20 years of practice. And I'll show you examples of that. Maintaining respiratory function so that you're able to continue to do whatever it is you can do for yourself. And then also training your loved ones or those who are caregiving for you as to how to best transfer you in a safe manner. That's a key. That keeps you mobile. That keeps you getting in and out of the house. And that's important for this and for this. Okay, any questions about any of that? No? Still with me? Okay. So this was just a flow diagram talking about the potential role of exercise, but more importantly, the benefits of exercise, which is, I mean, it goes without saying. We all know what the benefits of exercise are. I would argue that in someone who has a neurologically degenerative condition, such as MS, it's even more important. Many times I'll have patients come and say to me, you did X, Y, and Z for me, and I saw your therapist for 3 months, and I was here twice a week, and I'm no better than the day I started with he or she. And my answer is, can you imagine what would have happened had you not done it? True, right? Because there can be decline. So in many instances, therapies for neurodegenerative conditions, such as MS, are not there in hopes of making you better. But if we know going in that it's going to help maintain me at the level of function that I need to be at in order to maintain my independence in a safe manner for as long as I can, then I don't think there's any downside to participating in therapies. Does that make sense? So you're doing this as opposed to doing this. You're not on that slippery slope. Someone's helping you put the brakes on so you don't slide even further or slide even faster, right? And that's what this is really just making reference to. It's talking about brain health. It's talking about physical health and trying to attenuate or prevent disability from setting in.
Dr. Jean,
Yes.
as a doctor, I'm going for a checkup, and the doctor, I got a headache. Okay, I suggest you stretch against the wall. Like, why do doctors relate to amateur stretching? Is that just a scapegoat or?
So I won't mention stretching then when I touch on spasticity. I mean, look, we know definitively from the literature. So spasticity is a word that was introduced to me when I was probably a second-year medical student. And I promise you I had hair on my head then. What we know today, 25 years later, 27 years later, I've contributed to some of that literature. I tell you in the most humble of manners that stretching is the hallmark of keeping something like spasticity at bay. But even if I don't have MS, I, at my current stage in life, should be stretching 4 to 5 times a week. Stretching in some instances may even be more important than weight training. I'm not saying one is better than the other, but stretching is key to remaining supple, allowing the joints to move as freely as possible, even without spasticity as an underlying cause. So I don't know who told you to stretch because you had a headache. That wouldn't be my first piece of advice. But I understand what you're saying. But stretching is key to keeping all of us moving. You know, it's something we all need to incorporate into our lives, regardless of what's going on in terms of our.
So over lifting 200 pounds, just go to yoga, you get better results.
I agree with you. We've had this discussion before in clinic, right? I'm allowed to share that. So MS-related symptoms, how would you rate these? Would fatigue be number one? For those of you that have experienced it firsthand? Yeah? Any show of hands, fatigue number one? What are you doing for fatigue? So occupational therapists will tell me a lot about energy conservation and teaching patients about how to do things more efficiently because their gas tank is smaller now, or the way in which the car is burning fuel is less efficient. Take your pick, right? That's the analogy here. Someone had a hand up in the back. Go ahead.
I can listen to my body's needs. I just know like lately it's acting up now that I'm in my mid-40s. And I know I read my age, not yet. But,
I'm smiling because I'm saying I remember my 40s. So,
you don't look it. I went down.
that's kind of you to say.
No, but I just listen to my body, and if I'm sitting, I need to sleep. I need to sleep. My daughter, I thought, you know, you carry watching TV, and I go upstairs because I'm tired. I need to sleep. And why is shutting down?
So here's one thing I want to remind you all of, and I remind all of my patients about this. I'm going to trip over this cord, I know, at some point. Is that whether you have a diagnosis of MS or not, and I don't. So I apologize for saying this, but remember, father time, mother time gets us all. We're all aging. I can tell you right now, to be up at 3:45 in the morning to go and yell at a bunch of 13-year-olds downstairs was painful. I came home upstairs and I was drenched just from climbing the stairs at that time. Maybe it speaks to my cardiac fitness, but the point is that we're all aging in the background, and many patients when they come to see me forget that. They forget that. Thank you. They forget that we're all aging. And processes slow down, regardless of the fact that you have an overlying or underlying neurodegenerative condition. Now, in this case, it may be somewhat accelerated because there's two things acting in concert. And I don't have the science to back me up in that regard. But remember that even without a diagnosis of MS, there's nothing saying you wouldn't be more fatigued in this same situation. Maybe not to the same extent, I'll give you that, for sure. But keep that in the back of your mind. Cut yourself some slack, right? Anyone else have any comments on fatigue?
I was just gonna say with fatigue, like, but the fact that the person needs to rest, it's also the body's self-preservation to say, I need to repair itself. Does it not? Like when one is resting, because I just feel like your body is going into like some kind of recycling or doing something for you that we shouldn't really look at it as that negative. Like I look at my daughter. If she says she's tired and doesn't want to do certain things, I look at it, she's become self-aware of how far her body can go. And I have to respect that.
Absolutely. Absolutely. I mean, there is something called a circadian rhythm, right? It's the natural movement of the body. Cortisol is a good thing when it comes to the circadian rhythm. So you're fast asleep, and at about 4 o'clock in the morning, cortisol kicks in. Why? To have a sugar release to start waking you up as you approach 6, 7 o'clock in the morning as the sun rises. That's natural. If you don't sleep and you're awake, like my son was last night, cortisol is a bad thing. It drives your cholesterol levels up. It could be really bad for heart health, et cetera, et cetera, et cetera. So we have to respect the body and listen to the body.
Is there a difference between fatigue and just being tired? Because I mean, you asked me about fatigue as a symptom of MS. I personally don't think I do, but I get tired. Like when I shower in the morning, I'm tired. I'm not trying to go to sleep. I'm just tired. So is that sort of put that in the same bucket, or?
So if you believe in Utah's phenomenon, you've heard of Utah's phenomenon. So people with MS going to warmer climates and experiencing an exacerbation. How warm are your showers? That's right. So maybe subconsciously you found that with dialing the temperature down and making things a little cooler in the shower, you're not as tired or fatigued.
But I'll say something else.
Yeah.
The cold affects me, it stiffens me up. So if my shower is too cold, my internal temperature is too cold, everything just becomes too wet.
So your window of being in a good place where your thermostat is narrow. It's narrow. Okay.
But it's just, it's the fact that, you know, I still do shower on my own and do all that. But I just find because I'm standing up for such a long time, I get tired, and I'll say it, I shower, I go watch some TV in bed for about 45 minutes, and that turns me up again. I don't go back to sleep, but I'm not, like, I'm tired, I'm not fatigued to the point where I'm going back to sleep.
Is it a physical tiredness?
Yes.
Yeah, so maybe equipment might help to overcome that, right? Bath bench as an example, just as an example. And with respect to that, and I'll touch on this, but you hit the nail on the head there. You said when you're too cold, you feel tighter or stiffer. Do you have any spasticity, if you don't mind me asking? Okay, so you see my good friend Chris. Yeah, so Chris will tell you, because we published a paper on this one years ago with one of our residents, that there are things like noxious stimuli that trigger more tone or spasticity. Cold weather is at the top of that list, right? In my patients who still smoke, if they haven't had their 2 cigarettes, not with MS or with stroke, before they come and see me, they're actually tighter because their body hasn't seen the nicotine it's used to, and that's a noxious stimulus for them. For my female patients who are still menstruating, if it's that time of the month when they come in, they're tighter, right? If someone has a chest infection or a bladder infection, noxious stimulus, spasticity is heightened when they come to see us. There's a question in the back and another question in the back.
Can I connect with what you were saying? I had a case of extreme cold, so this was a few years ago. So I gone to Ottawa and I was in a hotel and the pool was freezing cold. I went into it and, you know, just experienced it. I got out of it and I said, okay, let me go back to my room and go for a hot shower. So it's too extreme. Whoa. And boy, was I in such excruciating pain. I couldn't even make it to the bed. I had to go. No. And my friend had to take me to come back from Quebec City to Toronto. We only made it as far as Ottawa, and every truck stop I made. No, nothing was working for me in the washroom. I couldn't even go to the washroom. I'm like, what's going on? And so we went as far as Ottawa ER. I said, that's too bad. You're going to the Ottawa ER. Now, this is employment. So we were in Ottawa ER, and they wouldn't let me go. Did all the testing, wanted to make sure we got everything. I got fibroid, MS, all that. And then I told the doctor the next day, so you want to leave us? And they allowed me in the ER vision. And they gave me some medication, you know, let me have a good night's sleep. It was awful, couldn't even talk. But I said, take off your doctor hat and please tell me, please talk to me. You know, what do you recommend? And she said, Tanya, everything inside there is old. You got to renew. Fibroids are dying. You're done having children, right? I'm like, yeah, just move it out, move uterus. And that was the best advice I got. And then came back, COVID hit, and I wanted to go for my surgery to get the uterus moved. Because I was done with my children. Not done with them, I love them, of course. That's my Adam in heaven and my 2-year-old, right? But I do know that I'm blessed with them. I know my Adam walks with me, my Trisha is right here, Tom's growing, comes here, and Sorry, I'm going to fail right now. I have to breathe oxygen into my brain. And breathe it into my system. Calm me down. So I can walk further. These are strategies I use even for my fatigue. And boy, is it the best medicine ever. And if I can laugh, you can make me laugh. It's the best medicine to my soul, my heart. I love meeting people, and this will happen. I mean, this is my story. If anyone wishes to know more, please, I'm open.
And thank you for sharing that. I mean, I really like these opportunities more for sharing of stories, because people then leave here saying, it's not just me. It is happening to others. And you learn from the experience of others, and you try and bring that into your life when you face a similar circumstance. You had a question back there, sorry. Fantastic. Are you taking, or is anyone taking any medications to help with fatigue? So does modafinil sound like something that's, okay, fair enough. So back when I was a resident, amantadine used to be prescribed, and I don't know what the science behind that is, if I'm being honest. It was more borrowed from the traumatic brain injury population, where it was used to keep traumatic brain injured patients more alert during the day. So I would see that used by people I was working with in the MS population. And it was actually a flu medication when it was first brought to market years ago. So I don't understand the science behind it. And if I don't understand the science behind it, I have a hard time prescribing it. I'm not one to quickly write a script. I need to be able to explain it to you before I can suggest it to you. And that's not always the case. I'm not going to tell you that I live by that law, but I try my hardest to. You know, there's times in life when the body is harnessing hormones differently and is more receptive to harness. So, you know, there's a lot in medicine we don't know, and maybe you got some of that from what Dr. Lee shared with you. There's a lot we know, but there's a lot. He said there's 95% of the studies, a lot of the studies are negative studies or negative trials that are not being shared with the world, right? So there's a lot of stuff we don't know. But if it's working for you, far be it from anyone to say you shouldn't do it. Yeah. Right. Yeah.
As I learned from Dr. Lee today, I've been taking Tecfidera for 5 years, and I've been noticing that I've been getting thin on the skull. And he just said Tecfidera side effects, you start getting thin on the skull. So maybe that explains side effect.
Yep.
Eventually you'll get to the Botox, you might explain some side effects and all that. But
Sure, we'll talk about that. Another big one when I see patients with MS is pain. It's not so much neuropathic pain, but it's more on the headache side that I see them for. Weakness, obviously. Urinary incontinence, for many that I see, if the disease has progressed, for sure. Incoordination, gait impairment, balance impairment. Sort of I group those three together. Cognitive decline, I can probably count on one hand as to the number of MS patients I see that have issues with their cognition. Right? Impaired respiratory function, not so much. And just by default, because this is what I do, and this is one area of my focus of my practice, along with my colleague, Dr. Boulius. We've been at it for 20 years at West Park. I see a lot of MS patients with spasticity. So we've collected many patients in our practice with spasticity. So what is spasticity? Spasticity, by definition, is a motor disorder characterized by velocity-dependent increase in tonic stretch reflexes or muscle tone with exaggerated tendon jerks, reflexes, resulting from hyperexcitability of the stretch reflex. That's a mouthful. It just means your muscles are tight. But it just doesn't mean that, because there's a lot of other types of muscle tightness. So the umbrella term for muscle tightness is hypertonia, okay? Hypertonia. And I don't want to confuse terms, but we got to keep things separate and teased out, because if we differentiate between different types of muscle tightness, then we can apply appropriate treatment strategies based on what type of muscle tightness you have. So outside of spasticity, other types of muscle tightness include spasms, which can happen to anyone, whether you have an issue with your central nervous system or not. Issue with the central nervous system, examples, stroke, brain injury, spinal cord injury, MS, cerebral palsy. Clonus. Clonus, you may have seen it before, typically seen in the lower extremities, but also in the upper extremities, where you can trigger it and you have shaking sort of a limb, typically your distal lower extremity. So it's a repetitive type of movement. Rigidity. Rigidity is more in keeping in those with Parkinson's disease. So muscles are tight, and it's kind of like a pocket knife. When you open up the blade, it's hard, and at a certain point, it snaps open. That's rigidity, clasp knife rigidity. But that's more in keeping in those with something like Parkinson's. Dystonia just means abnormal muscle tone. Dystonia, the most common form that I see, is either something like a writer's cramp. So you don't need to have an underlying neurological diagnosis to develop dystonia, a writer's cramp, or a musician's dystonia. So someone who plays the piano, for example, and does it for a living. Their fingers may just cramp and hold in a certain position. We don't know why that's happening, because there's no underlying neurological condition, but there is treatment for it. The more common form of dystonia that I see in my practice is cervical dystonia. So you'll see people walking around with head and neck in this position. No known underlying neurological cause, but muscle tightness. Treatment is focal, and it's done with botulinum toxin. The most common form you would know is Botox. Peritonia. This is a variable type of muscle tightness that develops predominantly in those with dementia. And we're in the process of trying to prove to Health Canada that this is something that they should fund toxin injections for. And the last is contracture. Contracture you may or may not have seen, and that's when muscles decide to, I'm going to put the microphone down for a second. So in order for a joint to move, muscle fibers have to slide over one another. When muscle fibers have been in a fixed position for an extended period of time, let's call it even a few hours. So someone gets admitted to an intensive care unit, and the team around them is trying to just keep them alive after a car accident, let's just say, for example. The goal there is to keep the patient alive. People are not there necessarily to move joints, and this is not a comment about care in the ICU anywhere. Their job is hard enough to try and keep someone alive. So things like moving joints at the ankles, at the wrists, at the elbows become secondary. But when muscle fibers sit in a static position for an extended period of time, the way I want you to think of it is someone has poured some crazy glue over those muscle fibers, and now they just kind of get stuck in a shortened position. If you come out of that ICU situation and the therapist catches on to this, or a physician like myself, mobilization will help to start to overcome that, assuming that there's no underlying spasticity. But if it's left alone for an extended period of time, that's when you develop contracture, where those muscle fibers become shortened and immobile. So now the elbow, and you may have seen patients with stroke whose elbow is sort of stuck in this position. And even if you were to put an elephant on their forearm, the weight of the elephant would not get their elbow to extend. Why? Because everything, all of the contractile elements that make up the muscle, have now decided to shorten completely and entirely. Okay.
Does that mean that there is no chance if you get the proper therapy?
Once we
Will
get
they have any
recovery or improvement.
recovery?
Yeah.
That's what it's
So great question. So I think once you get to contracture, I can tell you definitively, you're going to see my friend, the surgeon, and then pick the surgeon. If it's an upper extremity, you're going to see a plastic surgeon for potential tendon lengthening. If it's a lower extremity, maybe an orthopedic surgeon. So once it gets to contracture, there's no amount of oral medications, stretching, splinting, injections that are going to help overcome that. You're going to need some sort of tendon lengthening. And tendon lengthening doesn't necessarily mean cutting the tendon. If you think of the tendon as a rope is a lot of little fibers woven together, right? So what you'll do in the case of a plantar flexed foot that doesn't straighten out is the Achilles tendon will be just sort of nipped away at by the surgeon. And I'm oversimplifying this, but you don't cut through the entire rope. You just fray some of the fibers of the rope and then you pull on it to give it some more length.
But they're pulling on that same.
So what they're doing is they're lengthening this tendon here by just snipping away some of the fibers. Yeah, keeping the bulk of it intact. And then instead of in this position while you're in the operating room, trying to bring it into this position. And then once it's lengthened, typically they'll do what's called serial casting. So they'll put you in a cast that holds you at 90 degrees so your foot doesn't go back into that position. And then over time start to work on range. Okay? More commonly done in the pediatric population than anything else. But so, anyone want to hazard a guess at so the reason for this slide is we wanted to, about 15 years ago with a medical student, determine how many family doctors across the country in Canada knew what spasticity was. So we sent out a questionnaire to 1,000 of them. And the first question was, define spasticity. And we didn't want them to sort of write it down. We're going to give you a choice of 5. Is it a rhythmic series of muscle contractions? Is it an increase in muscle resistance? Is it a permanent shortening of a muscle or joint? Is it a velocity-dependent increase in muscle tone? Or is it sudden involuntary contraction of the muscle or group of muscles? So, what percentage of family doctors answered that question correctly when given a choice across the country? 50%. Higher or lower? Lower. I got 30% somewhere. Higher or lower? Lower. How low? Higher than that. Come on, they went to medical school for a long time. So I want you to remember that spasticity, as we teach our residents, it's a contact sport. It's not a symptom. Someone doesn't say, I have spasticity, unless they've been examined for it. Why? Because I told you it's a velocity-dependent increase in muscle tone. I have to move that joint quickly in order to see that catch or feel that catch. So it's not necessarily something that someone will describe. They may describe muscle tightness. We have a question in the back.
I want to give an example of what you're explaining right now, because I'm going through it with the class. I was in February, and with that being said, exactly how you said to exercise, that's what I have to do. I have to breathe into it and stretch it. If I can't sit, these chairs are not for me. I cannot. I'm sorry, I'm smiling. You're smiling.
It's good for you to stand.
Listen, I'm not doing that. I'm an educator as well. But with that being said, this is what I do because I'm going through it. I don't say exactly about spasticity because that's your terminology to use in your medical field, right? For me, I'm not going to go sit live by that MS book. That's the way I function. I live it. The theory is there, but I've got to connect it with the experiences, and that's how I can say yes. I experienced that what you just said. I listen to you. I can't see that far because my eyesight's not working. I have to go and get higher power. Smiling again. I pay attention to all of that. But that's me. No, sorry.
No, that's okay. You're sharing. You're sharing.
I just got an example to connect with.
So we were stuck at less than 30%. We got as low as 5%. I'll get to the slide, I promise. So just remember that spasticity is a clinical sign. You have to be examined for it. It's definitely not a symptom. Here's an example of it. Let me just play this. Now, this is not a patient with MS. This is a patient very early on in my practice who had stroke. So you can see, I'm going to show you how I'm moving her shoulder and trying to take it out. I'm definitely going to show you her elbow, and I think I show you her wrist, but you'll really see it at the elbow. And if I use the pointer, so this muscle here, this one that's popping up here, the beer drinking muscle, brachioradialis. So you can see it's hard to take her shoulder out. And if I had the volume up, she wouldn't be happy with me moving it quickly because it's a little bit uncomfortable. But you see, you have to move it quickly. At rest, all you saw was that the elbow was flexed, but you can see that muscle popping up when I try to move it quickly, and you saw that catch, yeah? So spasticity, as we said, it's italicized there, a velocity-dependent increase in muscle tone. A rhythmic series of muscle contractions is clonus. That's that jerking of the foot that I told you. An increase in muscle resistance throughout a movement punctuated by rhythmic interruptions in the increased resistance, that's rigidity, like that clasp knife I told you, or that pocket knife. A permanent shortening of a muscle or joint is contracture. A sudden involuntary contraction of a muscle or a group of muscles, that's spasms, which any one of us can experience, okay? So the answer is, out of 1,000 of them, only 15% of them responded. So we only got 150 responses back, which is pretty good, actually, okay? When you look at this type of a study, it's not bad. It's not the best, but it's not bad. Only 25% of them knew what it was. What's the reason for telling you that? The reason for telling you that is if you think you have any issue with muscle tightness, my muscles are tight, and you don't know what it is, you better bring it to the family physician's attention, because you're probably going to get to see the family physician before you can see a specialist. And with continued education, hopefully they learn that programs like ours exist. It's not the only one in the country. It's not the only one in the city. There's a nice program at Baycrest. The physician who runs it at Baycrest runs a smaller version of it as a subset, I believe, of the ALS clinic, which is part of Sunnybrook. But I think that was all brought in under the roof at Baycrest. Our friends at TRI are running a program out of the Rumsey site, the Lyndhurst site, and also the University Center site. And those are the bigger programs in the city. But they exist in a multidisciplinary fashion sort of across the country, but they're not abundantly available is what I'll say, okay? But if you've got muscle tightness, you're gonna need to bring it to the attention of your primary care physician and say, I know that something can be done about this. You need to send me to go and see someone who knows more about this. Because stuff can be done, and the earlier the better. So we've talked about who can develop spasticity. This is the population for today's discussion that we're most interested in. How does it present? It presents in a focal manner. So here you see someone's big toe sticking up, and that's it. Why'd that be a problem? That'd be a problem putting on a sock, putting on a shoe. Skin breakdown over the top of the foot or top of the toe. It can be multifocal. So here, that's Dr. Boulius, by the way, in the picture. This is a patient of his with stroke who has multifocal. So it's localized to the shoulder, elbow, and wrist, like I showed you in the patient whose video you just saw. It can be regional, and we'll see examples of that in upcoming video, or it can be generalized. Now, this is someone with traumatic brain injury who has it impacting his upper extremities and his lower extremities. Well, we talked about if we leave spasticity alone for long enough, it can turn into contracture, and we don't want it to go there. We don't want it to go there because then we need surgery. It limits active function, reaching, grasping. It also limits passive function. So if you're unable to do things for yourself and someone is trying to do them for you, dress you, bathe you, transfer you, toilet you, it can be problematic. We have, so I go into long-term care homes to manage patient spasticity because for them to get to us at West Park is a challenge. So I'll go to about 15 nursing homes in the GTA to manage patients as well. And there we have nursing staff telling us after you manage their lower extremity spasticity, it only requires one nurse to dress them, and it's done within 5 minutes. Before that, it was taking up to 3 people and taking 15 minutes because the legs were so stuck together, so to speak, and we'll see examples of that. Spasticity and pain are also an issue. Dependence on a caregiver if you're spastic obviously reduces quality of life. In our younger patients with CP or with MS, poor self-image. You're walking around with an arm like this, or you're dragging your foot. Social considerations, right? So it's the use of Botox as an example for an aesthetic reason, but a different type of aesthetic reason, not to get rid of wrinkles, but to make you look, I don't want to use the term normal, but if you're a teenager, that counts. That counts. And also decreasing risk of falls are reasons for wanting to treat it.
That's why we're addicted to social media. We could look normal. I could look like I don't have MS in the computer.
So So how do we measure it? I'll go over this very quickly. It's called the modified Ashworth scale. It's something that we use to see patients pre and post treatment. It's described there, but know that there are numerous different scales that we use to measure it and objectively collect the data. The higher you are on this scale, the worse your spasticity is. 0 is no spasticity at all. 4 is contracture. Okay. We've seen that first example of spasticity. I'll show you a second one here. If I can find the... So I described focal, multifocal, regional, and generalized spasticity in a previous slide. What would this be? Spasticity, but what type of spasticity? Is it focal, multifocal, regional? So yeah, so multifocal if you're just looking at the upper extremity, but because if it impacts her arm and leg, it would be regional. Okay? Regional. Generalized would include all 4 limbs. So this is regional spasticity. And this is someone with a stroke. So lots of examples of stroke in our practice because that makes up about 50% of the patients we see, 50. MS probably makes up about 10 to 12% of the patients we see in our practice. And Chris and I together are probably seeing about 700 patients in our combined spasticity practices at West Park. So let's talk about MS-related spasticity. There are studies out there that are highly variable, but most of them will say up to 80% of patients with multiple sclerosis will develop some form of spasticity. Okay. Then when we delve into the literature a little bit more, 35% of those will have moderate spasticity. What the heck does moderate spasticity mean? It means, if we go back a couple of slides to the modified Ashworth scale, that was the reason for putting it up there. You're sort of in here. 1 plus, moderate level of spasticity. It's there. It may not be problematic, but we're aware of it. It's mild, moderate. Only 25% in most studied with MS who have spasticity have severe spasticity. And severe would be definitely above a level 2 on that modified Ashworth scale, probably a level 3, approaching a level 4, if not already at a level 4. It's usually only these patients that we're capturing for the purposes of treatment in our practice. What we teach our residents is just because you have spasticity doesn't mean it needs to be managed. Sometimes it can just be monitored. Because spasticity in some instances is good. I'll give you an example. If I've had a stroke and I have weakness on the right side of my body, my gait is going to be affected, and I'm going to be walking by sort of swinging my leg around, what's called a circumducted gait. I don't want to go too far. I'll probably pull that speaker down, right? But you can see I'm not bending my knee. That's because I have spasticity in my knee extensor muscles called my rectus femoris or quadriceps. I need that tone and that tightness to allow myself to weight bear on this side. If Dr. Ismail went and put a needle into this muscle and reduced the tone by injecting toxin and weakening it, because I'm weak on this side as a result of the stroke, my knee may give way and down I go. So sometimes treating spasticity is not necessary, even though it's present, because it can be helpful to the patient. So you apply that to your situation and determine whether or not it's a good thing or something that needs management. So typically, most of the patients we're managing are impacted in some way by their spasticity and require it managed. Spasticity triggers. So before we tackle anyone with spasticity, Peter?
I know a lot of our members have spasticity, but a lot of them also have swallowing issues. Does that contribute to the swallowing issues? Especially if the spasticity is up in the upper part?
That's an excellent question. So what we know about the digestive tract, the esophagus, is the top third of it is volitional, meaning you have control over the top third of your swallowing pipe. The bottom 2/3 is under autonomic control. So once food gets past a certain level, peristalsis starts to develop, meaning the tube starts to contract itself by that stimulus. It's being filled from the inside, which triggers, okay, we need to push food down. And then it goes, right? It makes its way through the GI tract. I would say that spasticity will not affect the esophagus. If there are issues with the top third of the swallowing process, it's because of demyelination that's happening centrally as a result of MS that's impacting the nerves that control that swallowing process. Okay. So before we start delving into just managing spasticity because it's there and it's moderate and severe, we have to make sure that you don't have a series of things going on, various triggers. So we talked about too hot a shower, too cold the weather outside. We talked about my patients, my stroke patients, those naughty patients that smoke, right? Question?
I just wanted to add, stress adds on to what one has.
Absolutely. Absolutely. Stress can definitely trigger more spasticity. So that's the psychological factors you see at the bottom of this list here. Fatigue, ingrown toenails. Why? Because they could be infected. Any type of infection, bladder, chest, skin can trigger more spasticity. Tight clothing, poorly fitting orthoses. So braces that you might be wearing because they're rubbing the skin might trigger more tone. Poor posture in bed or in a wheelchair because of pressure issues and pressure ulceration. Here's some other things that you can't control that can also trigger more spasticity. So a clot in the veins, noxious stimulus, it can trigger more tone. So what we're doing when we're seeing patients before jumping in to treat their spasticities, are there any things we can eliminate to reduce the amount of tone? And then see them again and see how bad that spasticity really is, because maybe it takes them from a severe category to a moderate category, a moderate to a mild category, which means they don't need further treatment. So just because you have it doesn't mean it needs to be treated, because there may be other ways to get around it. So the questions we ask before we treat, assuming that we've cleared someone of all of those other things, is does the spasticity significantly affect function? Is there a risk or presence of complication? And does spasticity result in pain or discomfort? And many of my colleagues, I was just on a call with someone last night across the country. He and I run a training program for various physicians who want to learn more about spasticity management. And we've been doing it virtually since the pandemic. He and I go back and forth on whether or not spasticity causes pain. So the jury's still out on that one. Yes?
On the screen before, I seen kidney stones.
Yeah.
Spasticity cause kidney stones?
No, it's the other way around. It's that if you have kidney stones, it may heighten your spasticity or bring it out. It's the other way around. These are triggers for causing spasticity.
COVID time, I was rushed to Marcus Hospital, which is now Oak Valley, and my kidneys had failed. They say that I have not been chances I get, but I'm related to spasticity which you're describing. No pain whatsoever.
Okay. Okay.
That's me.
Yep.
Each person can do different, but that's me. It's not just today. Since I was 18 years old.
So while you're sitting here, just hold your fingers clenched in your palm. Try it for 3 minutes. Let me know if it's uncomfortable. I'm going to tell you, I've done it enough and done this enough to know that it's uncomfortable. So I don't know if you have spasticity that's causing finger flex or tone. Maybe it is painful. Maybe it is painful. So here's an example of, again, upper limb spasticity in someone who's had a stroke again. And all he has to do is grab that cone. I say all he has to do. Grab that cone, bring it to his chest, bring it down to his lap, bring it up, take it out, put it down. And you can see he can't get his hand around the wider part of that cone, yeah? You're going to see this guy again in a bit. So when it comes to my patients with MS and related spasticity, if we talk about how does it present in the upper extremity, typically the shoulder is tight, so the arm is tucked into the side. It's hard to get it out. Why is that important? To wash in the axilla, to put on a jacket, to put on a t-shirt, to take it off, right? Elbow flexor tone, like you saw in that first patient whose brachioradialis was quite prominent, so the elbow is flexed. Sometimes I see it in the wrist flexors in my MS population, but definitely in more advanced cases or people who've had MS for longer periods of time, more so I'd even say in primary progressives, is involvement of the finger flexors. Okay? So those are typically the muscle patterns I'll treat in the upper extremity. In the lower extremity, it's the hip adductors. So think about the muscles you'd use if you were sitting in the saddle riding a horse. You'd have to bring your knees together, right? So those are your adductors. And I'll show you some anatomical sort of images of the muscles that we would tackle. The knee extensors we talked about, and you'll see an example of that in an upcoming video. So your quadriceps, knee flexors. So sometimes I'll have patients who present in bed with MS, pretend that they're lying on their left side. They're flexed at the knees and I can't get the knees straightened out, okay? And then ankle plantar flexors, which we talked about for people requiring surgery, so pointing down of the foot. Yes?
For myself, for years, my shoulders, especially when I'm sitting, I feel like I have to stretch them out
Backwards.
all the time. Like I feel like they need to wrap or.
But backwards, correct? You feel you need to take them back to expand your
I
chest.
feel like I have to like rack it, it'll feel better, but it never does. It's like I never rack it once it like, is that spasticity? Is it kind of?
It could be. It could just be poor posture, which is me. Maybe you've seen me. I'm not saying you do, but I mean, that's me all the time. That's all of us. We're on a phone, we're on a computer, right?
Yeah.
So sitting upright is something I'm reminding my kids to do constantly. I'm reminding myself to do constantly. So an examination would help sort that out. But yeah, the pectoralis major, and I'll show you that muscle in terms of, that's the primary shoulder adductor, will help you round your shoulders the wrong way. So bodybuilders typically tend to be this way because they remember the front because that's what they can see in the mirror. They forget the back. So these muscles are overdeveloped and then they bring you forward. Okay. And that's one of the roles of pectoralis major. So those are typically the muscle patterns that we're treating in those with MS. So that's just a list of the muscles. I'm not going to bore you with the anatomy. If you have questions about the muscles that are tackled and why, so this just shows you various muscles. These are elbow flexors, biceps brachii and elbow flexor, brachioradialis, that's the beer drinking muscle again, elbow flexor. Then we've got the wrist flexors, so flexor carpi radialis, flexor carpi ulnaris, and then flexor digitorum superficialis, which is responsible for bending only these four fingers at the second joint. So that's the first joint, that's the second joint, that's the third joint. So the first joint is called your MCP. The second joint is called your PIP or proximal interphalangeal joint. So that muscle, if you see, actually lives up in the forearm. So to inject it, you're injecting in the forearm, although it's controlling movement down here. Okay?
Do you show an image where the needle is going into the muscle?
I don't have any of those images, but I will show you an image of ultrasound with sort of the needle, tip of the needle in the muscle and injecting the fluid. And then in the lower extremity, we have rectus femoris. So here we have the quadriceps group of muscles, that entire mass, the darker one up front. Rectus femoris, if I can keep my hand still enough, is this right here. So it's an interesting muscle because it's been studied extensively in the post-stroke population. Here I am talking about interesting muscles. I know, yawn. Saturday afternoon, interesting muscles, right? You see what excites me. I don't believe I actually said that. My kids are going to watch this on YouTube. Yeah, it's an interesting muscle because it's a long one and it crosses the hip joint and it crosses the knee joint. So it does two things. It flexes the hip and it extends the knee. It does two things. But it's been studied well enough for us to know in the post-stroke population that it's the only muscle of the four muscles in the quadriceps that needs to be injected in order to get someone to bend their knee better or more when they're walking. Okay, so we apply that to the MS population. Then we talk about the hip adductor. So the hip adductor, I'll trace it out. Adductor longus is that muscle right there. Okay, this one right here, you can see the arrow pointing to it. It's the one that's primarily, in my most humble opinion, responsible for this, bringing the knees in. So those patients I told you about in the long-term care facility who need loosening of muscles to bring them apart, to clean the perineal region, to put an undergarment on, to put pants on and off, to wash them That's the one that we'll primarily tackle, or at least that's what I'm preaching these days. Yes,
When you say poke, you're poking each individual muscle?
that's correct. So when you come to see me, and I'm saying that to you, usually I'm using a clavis. Sometimes we've done it with ultrasound on rare occasions, but I'm using a clavis, and I'll show you what that is. And then, of course, the muscles that point the foot down, or the ankle plantar flexors that live in the back of the leg. So those would be gastrocs and soleus. So here's an example of a patient with MS. And this is an old picture, and you'll see why, or an old video. And then you can have a good chuckle, because my kids did. Hey, you can tell by the shirt, but you see that? I'm trying to take his legs apart, and the other leg is coming along for the ride. That's how tight he is. In the normal situation and circumstance, that right leg would come out very easily. His left leg is coming along. So this was a gentleman with primary progressive MS. He was about 5 years into his diagnosis when I met him. And you can see I'm trying to bend his knee. I promise you, I'm trying like heck to bend that knee, and his rectus won't give way. Exactly. Yeah, I'll need therapy after that. So you see how tight his rectus was there too. So in him, we were injecting his adductors and his rectus femoris. It made a difference for a while. Eventually, I had to send him off to see somebody else, and I'll talk to you about another form of treatment, not just toxin injections and oral medications that help make things better. So this is my favorite slide when we talk about treatment options for spasticity. You guys all still with me?
Yes.
Yeah? Okay. Surgical options. So as we go along this x-axis out to the right, things become more permanent. Once you lengthen a tendon, you can't shorten it again without more surgery, right? It's permanent. So surgical options, more on the right side of the house. Reversible options, more on the left side of this x-axis. And as we go up and down the y-axis, they tend to get more focal as we go higher and tend to get more general as we go lower. Most of my focus is up in this area, as well as using oral pharmacotherapy, because I'm not a surgeon, but sometimes we do need the expertise of a surgeon based on patients who've had contracture, right? So we focus more on focal chemodenervation, therapy, bracing, splinting, stretching, and oral pharmacotherapy. So is anyone using any of these medications listed here for management of tone? Yeah. So these may seem familiar to you. Baclofen has been studied the most and the best in the MS population. It is said to work at the spinal level more so than at the brain level. But it is most and best studied in the MS population because it hasn't been well studied in the traumatic brain injury population or the stroke population. Foolishly, we do use it in those populations, but ineffectively. Question? So side effects. Yeah, side effects. Any other comments on oral medications?
It's more shocking question. So I started on faculty about a month and a half ago. I went to see Dr. Boulias 2 weeks ago, and he was a little concerned about baclofen, treating spasticity with baclofen on a general level versus what he was doing, which is more focused. It wasn't really a concern, but maybe there was too much treatment. So is there, are there additional side effects when you're treating spasticity locally with, let's say, Botox, and then adding a baclofen, which is a general, it just works on the whole body?
So oral medications to me have fallen out of favor, and they've fallen out of favor. Like it's if you have, so I've showed you 4 different types of spasticity in terms of presentation: focal, multifocal, regional, and generalized. Only in that generalized category does my mind go towards this, because I need it to get everywhere. You take it by mouth, or you take it by G2 if you can't swallow. It needs to be processed by the liver or the kidney, and it goes everywhere. It doesn't pick out the muscles that need it. It goes absolutely everywhere. So if you have generalized spasticity, I think these are reasonable treatments, but you're always trying to balance effect versus side effects. So most of the literature tells us that we need to not max you out on any dose of one, but gradually introduce another medication at a lower dose so that we're keeping the total dose of each medication relatively lower, but we're using them in combination. Because, and I won't get into the science of where these work in the central nervous system, but if you want to ask me, I'm happy to share with you. They work at different spots in different receptors in the central nervous system. But the side effect profile is quite horrendous with some of them. A compounded agent. Short answer is no. Theoretically, it shouldn't. Theoretically, it shouldn't. So I prescribe a lot of compounded agents because the other side of my practice is something you'd consider sports medicine. So a lot of people come to me with focal pain that's not going to be operated on by an orthopedic surgeon, and compounded agents work well because there's the target, shoot at the target, right? As opposed to taking something by mouth. Yes.
So sorry. Just so I understand, are these like, please forgive me guys, meds that are going directly to the muscle in question so it's a local kind of?
Excellent question. So this is why I love sort of this series of slides. These series of slides are more than 20 years old because I studied off of them then. I created them back then. So these are all working centrally in the brain or the spinal cord, okay, at receptors there. So are these. This one, although you take it by mouth, it exerts its effect at the level of the muscle. By the time it gets to work, it's working at the level of the muscle. And it's preventing release of calcium at the level of the muscle. And calcium release is needed for the muscle to contract. So this one works down at the level of the muscle. This one works centrally. So all these work centrally. This one works at the level of the muscle, but still taken by mouth, which means potential for side effects.
More so than the other one?
Potential for more side effects.
Oh, more side effects.
Yeah.
More so than the other one.
This one, I can't even remember the last time I wrote a prescription for it. If anything, when I see patients that are on, I won't say all the time, but in general, if I see them on oral medications and the problem is anything but generalized, I'm usually trying, like the Dickens, to get them off of oral medications. And they wake up. They become more functional. You know, it's not everybody, but it's the majority of patients. You know, there's the problem. Those are the tight muscles. Let's treat it with a targeted approach.
We provide multiple prescriptions. This is for this, but it could cause both. It could cause constipation. So this is for the constipation, but it could cause headaches, and this is for the headaches.
You can start going down that path. I don't, because I'm not in favor of oral medications for the management of spasticity. You know, these are different surgical options. We can talk about those and revisit that if we need to. And then really here are the injectables. So before botulinum toxins, the most famous one you know is Botox, which is as well branded as Coca-Cola, by the way. It's the second best branded product in the world. Botox is one of 3 botulinum toxins available to us in Canada. Botox is made by a company named AbbVie. We have Dysport, which is made by a company named Ipsen, which is a French-based company, very extensively used in European countries. And then we have Xeomin, Xeomin, made by still a family-owned company called Merz, M-E-R-Z, which is German-based. So all 3 are available for the management of spasticity. Unfortunately, funding for patients with MS and spasticity continues to be a thorn in my side. And I don't know why. If someone has had a stroke, brain injury, spinal cord injury, or has cerebral palsy, I write an LU code, LU412 or LU413. My colleague and I, Dr. Boulius, went and spoke to the ministry 18 years ago to get these LU codes put in place. And whatever we said, we think worked because they are in place. But they kept our MS patients off the list. To this day, that remains the case, and I don't know why. It doesn't mean you can't get Botox funded for MS-related spasticity. It just means we've got to do a little more paperwork, something called an EAP, which is the Exceptional Access Program here in Ontario. So it's just a different submission. It takes a little while longer to get the approval, but we do get it. Yes.
I experienced spasticity in such a way that my poor husband was the victim of my left leg kicking him most of the night
Yes.
in bed. Yeah, so Dr. Bruno sent me to, she invited to Toronto Rehab.
Yes.
A doctor, and he was treating me with Botox.
Yes.
I was lying on my stomach, and he and the nurse were injecting into the back of my leg.
Yep.
The first time, we had to pay close to $1,000 for it because it wasn't covered for MS patients. That's
Right.
why I'm reacting.
Yes.
But then they encouraged me to write to the ministry and so on. So I wrote letters, I attended meetings and so on, and happy to report to you the next 3 sessions were free.
Fantastic.
And apparently it's approved now for people with multiple sclerosis. And just for curiosity, it helped me. Originally, I was told that we need to come during the year at least 3 or 4 months.
Correct.
After 3 sessions, I'm healed.
Good. I'm glad to hear that. That's fantastic. That's great. Yeah. You sleep better at night. Yeah, so for our MS patients, it's not onerous at all. We've got someone dedicated to that process in our program, our clinic coordinator who takes care of the Exceptional Access Program EAP application. And you know what, we haven't gone back to revisit the numbers, but I don't think our MS patients are waiting more than a month. Having said that, if you come and see us at West Park and you need treatment, you will get it the day you come and it won't cost you a penny. I promise you that. We have float vials that we can use in a limited capacity for patients that require it. So the EAP can be happening in the background. And usually once the EAP is approved, I think the first time it's approved for a year. And then once you go back in and apply again after a year, it's typically a 5-year approval. So the approvals only have to happen every once in a while once you get approved. So yes.
We have a couple numbers that went to their doctors to get Botox. They have MS, a secondary progressive. But they said they were not candidates for it. What constitutes being a candidate to get Botox? Not.
So that's a fantastic question. So we can go back to that moderate severe slide I showed you. But more importantly, if you come to see us at West Park, I won't say me, if you come to see us at West Park, and hopefully most physiatrists that you will go to see, our whole job as a physiatrist, as I see it, is to try and get you as functional as possible or keep you as functional as possible with whatever residual function you have, period, full stop. Having said that, there's a lengthy discussion up front when I see you in consultation about what are your goals or what is your primary goal for wanting this treatment or seeking this treatment. And maybe some people don't spend a lot of that time up front. Maybe they do, maybe they don't. But we have a whole team around us that helps us vet that goal, distill it down into something that's very specific, that's easily measurable, and that we can achieve within a defined period of time, because that is the purpose of rehab. Rehab doesn't go on forever, right? It's got to be goal-oriented and time-limited. So it's all about picking the goal. And the example I give is the gentleman who had seen me after a stroke. He was right-handed. I know there's a lot of stroke stories here, and I'm sorry, but it's a good one. He came to see me. He's probably in his late 60s, a pretty dense hemiplegia on the right side, previously right-handed, as I said. And I said, "What's your goal?" And he said, "My goal is to golf." So I said to him, "Were you a golfer before you had the stroke?" And of course he said, "No." I'm not kidding you. So we quickly crossed that one off and we moved on to his next goal. Not a realistic goal. It's not to say you won't be able to do it, but the likelihood is slim to none based on the fact that this is not how you were wired before this happened. As an example, okay? As an example. So it's all about goal setting and fine-tuning the goals and then determining whether or not this is the appropriate treatment to help you achieve that goal, I guess is the best answer I can give you. Does that make sense?
Yeah. So I guess your other alternative is to get another medical
Opinion.
recommendation.
Yeah. Yeah.
Because I think it's all based on what a physician's perception is, if it will help them.
And no harm done in that. You heard Dr. Lee say it too, right? Someone was saying that we don't feel like we're getting the right treatment wherever we're being seen for MS. You can seek the opinion of another group or another individual that does this and does this regularly. Yes. Correct. Yeah.
Dr. Ismail, you may also want to bring to a point that if you're seeing not a good doctor, he can cripple you. That's almost
You're not wrong. Because once it's injected, it's exerting its effect for 3 months. I forgot to tell you that, right? When botulinum toxin is injected, you can't take it out. You can't stop taking the pill and have it, secrete or excrete itself over the next few days, right? It's there for 3 months, typically. By 10 weeks, you're going to definitively see it wearing off, but you're waiting a long time for that to happen. So it needs to be in the hands of someone who's skilled in knowing muscles, where they originate, where they insert, how they act on their own, but how they act in synchrony, and how to find those muscles.
If they mistakenly insert the wrong spot, they can cripple you.
Correct.
Oh my God.
Yes.
Baclofen pump work.
I'm getting there.
Okay.
Great question.
Okay.
Great question. There it is. Look at that. Next slide. So that gentleman you saw with the tight hip adductors and the knee I couldn't bend, he went on to see my colleague, Dr. Burns, at Lyndhurst. And Dr. Burns runs the intrathecal baclofen pump program for adults in the city of Toronto, which we hope to share in as soon as we become one big family. So we're already in discussions there. We want to sort of grow the program and help support him because he's the guy with his nurse practitioner. So he himself is concerned. But that intrathecal baclofen pump is essentially the diameter of a hockey puck. But think of something that's half the thickness or a third of the thickness of a hockey puck. And it's got a little sort of nubbin in the middle of it that's rubber. And this is implanted by a neurosurgeon just underneath the skin, so you can sort of feel it and even see it. But you can palpate that little rubber stopper. And that rubber stopper is where you inject liquid baclofen, which is delivered by this pump. That's a pump. And it's controlled by Bluetooth. So when you come into the clinic to see Dr. Burns and his nurse practitioner, they're plugging in values that tell the pump how much of that liquid baclofen to deliver into this catheter, which has been inserted also into the spinal canal. So it's running adjacent to the spinal cord, and it's bathing the spinal cord with liquid baclofen. So this works really well for those who have spasticity in the lower extremities. Why? Because no matter how high up this catheter is, gravity is always on. So let's say it's depositing baclofen here. I'm not telling you that some of it won't make its way up here, but because gravity is always on, it's pulling the baclofen down. So people, in my experience, with lower extremity spasticity tend to benefit more from an intrathecal baclofen pump. So that used to be about $10,000. Maybe that's $15,000 now. I'm not sure.
Is that permanent in your body?
Yes, until it's time for a replacement or until it fails.
Do I qualify?
You don't need it. You're far too functional. I know that. I'm allowed to say that, right? Good question. We have to ask Dr. Burns that. But typically, I don't want to give you the wrong answer. They have funding for installation of 10 of these pumps at UHNTRI a year. That's what the funding allows for, which means the surgery, and I believe the pump is paid for. What isn't paid for is the liquid baclofen. So that's where you need funding. Yeah. Question or comment?
It's the same thing like when a woman is giving birth to a child with an emergency situation with an epidural.
That's exactly right. So the test for it is actually similar to an epidural. So it doesn't just go in. You actually go and spend a day at the Toronto Western. You get taken into the operating room. The anesthetist does a lumbar puncture and gives you a small dose of liquid baclofen to see if there is an improvement over the course of the day. And if there is, then you qualify for the implant. So it's a process.
My next question, so if a person doesn't know they have MS and they're diagnosed once, they have the first time, 4 months later, what are the side effects of doing something like this to an individual, let's talk about female, down the road?
Yeah, is the female still wanting to have children?
No.
Okay.
Okay, let me give an example. So my first child, I didn't know I had MS. I had my 18 hours labor pain. And then it came down, so he was there ready to push him out. And So next thing I know, was 3 doctors, 6 nurses are in the room, and I really need, so we're getting ready to give birth to him. And because they had to give me epidural medication to tone down what do you call it?
Well, to me, essentially to numb you from the waist down, right?
Yes.
Yeah.
So anyway, so what did so they give me the epidural, not the epidural, all the medication. I can't use the right terminology at this point in time. And so that was given to numb the pain because they had to do an emergency C-section.
Correct.
And then 4 months later, after my son's born, I come to I'm in the hospital, let's see, one was stolen, and then let's see, Mike's, to learn that I have multiple sclerosis. Do you think that this numbness of the spine can have its after effects later on?
Typically, no.
That could really sell the MS.
The short answer is no. If you think of the thousands, hundreds of thousands of epidurals that are done just in Canada a year for various reasons, no. That would have been earmarked or flagged or red flagged a long time ago. Yeah, that would be the short answer. Any questions about intrathecal baclofen? You know.
Someone in your skull to reduce wrinkles? I'm kidding.
So here's MS-related spasticity. And remember all those bad things I told you about oral medications and I'm giving it away? Just describe what you see. Anyone, don't be shy. Just tell me what you see. What do you see? No, you see spasticity, but no, you don't because you haven't put your hands on the patient to measure it. Remember? It's a velocity-dependent increase in muscle tone. What do you see? Is she bending her knees adequately when she walks? Her knees look a little stiff, don't they? Right? Correct. So not as fluid, right, with the movement, a little stiff. So she has spasticity that's not as bad as the gentleman I saw you, but her spasticity in her knee extensors, 2 out of 4 on the modified Ashworth. So moderate spasticity. So I tried injecting her rectus femoris. It's always good to learn. She comes back and she looks exactly the same a month later. By now, the Botox should be working. Within 7 days, it should have its effect. And I'm thinking, what's going on? So now I go back and I say, did you have any infections? Bladder infection, chest infection, skin infection? Have you changed any medications? Any new stressors in your life? Trying to get rid of all those triggers, right? Nope.
It's a nice dress.
She says to me, the only thing that works is something called diazepam. And diazepam was on that list of no-no medications I told you you shouldn't be taking. It's a benzodiazepine. With benzodiazepines, there is a tolerance that you build up to them over time, meaning you need the same dose to exert the same effect. After X number of years of using it, you need a bigger and bigger and bigger dose. Hard on the liver, a lot of side effects. So I said, okay, I'm going to give you diazepam. Here she is on a month of only 2 milligrams 3 times a day of diazepam. The only time in my life I've written the script or started someone on it. Oh, come on. Hang on. Here we go. Ready? Maximum dose of diazepam, by the way, is 60 milligrams total daily dose. She's only on 6, so a tenth of the total. Magic. It's not perfect. She's still using the walker, but moving a lot faster down that same runway, that lousy little runway that we have in clinic, right? See? Amazing, right? So we can't paint everyone with the same brush. With MS, what's different about MS than any other diagnosis I've told you about spasticity is those people are all stationary targets. Once you have your stroke, assuming you've not had another stroke, the way in which you present is going to be consistent every time you come to see me. Once you've had a brain injury, God forbid, and it's settled, the way you present to me is going to be the same every time. And I go down the list. With MS, what I say to every patient is you are a moving target, and you guys know that better than I do. Where you are in your relapsing and remitting cycles, where you are in progression, whether it's secondary or primary, is going to be different every time you come to see me. So that's going to require more attention on my part and a bigger discussion. Where do you think you are? And how much has it progressed? So there's no one size fits all type of treatment when it comes to spasticity. You saw this gentleman earlier on. He was trying to pick up the cone, right? Remember the task was grab the cone, bring it to your chest, down, up and out, and let go. So he couldn't do it up in the first video. So that's him pre-treatment of any sort. Here he is after 2 sets of injections, so 3 months apart, and 3 months of therapy. If I can, come on.
Can I ask a question?
Yes, you can.
Is he on the left-hander?
No, that's the side of the body that was affected by a stroke. So that's him 3 months later. And in this last video, almost 9 months later.
Where's the injections you're doing on?
So in all of those muscles we mentioned before, so in him, it was his pectoralis major, his elbow flexors, because you can see up in that first video, he's actually leaning forward to try and grab the cone. He couldn't open his wrist and his hand. So his wrist flexors, his elbow flexors, his chest, and his finger flexors. But also with therapy, this is not just a function of toxin. Please don't take that away from this. This doesn't happen without the help of our marvelous team of therapists that work with him for, very specific reasons. So, what I'm going to do is, okay, here's an example of focal spasticity. So what do you see? Big toe sticking up. Big problem for this patient. Huge problem for this patient. Putting on a sock, going through pairs of socks, wearing through the top of leather shoes because the toe is always sticking up, having had ripped that nail off in some instances. So injected one muscle called the EHL, which lives in the front, which lives sort of along your shin bone. And here she is, I promise you, a month after the injection. Remember, it was the right foot. Toe's not sticking up anymore. Right? It's not perfect, but it's functional. I'm not going to show you that one. That's not necessary. So how do we localize muscles? I better 20 years into this, more than 20 years into this, 29 years into the practice of medicine, I better know how to find muscles with my eyes closed. So trust me when I tell you that I can do that. I know where they originate. I know where they insert. I can find them in an X and a Y axis. Why do we use localization? So some of you who are being injected will have seen this machine called the clavis. You can use it to listen to muscles by pressing that button. You can stimulate muscles when the needle is in the muscle by pressing that button to localize very specific fascicles of the muscles you are looking for. So what we know from the medical literature, and the other way to localize muscles, of course, if you know what you're looking at, is using an ultrasound machine. And this is an example of me injecting the back of someone's leg, so their calf muscles. What you'll see is that the needle is, so there's their gastroc right there. Just believe me when I tell you that. That's their gastroc, that's their soleus. The gastroc is getting thinner. My target is the soleus. You'll see something coming in here that's going to disturb the skin, the fat, and then the muscle. You can see it. See that point right there? It's coming into the muscle. I think it's there now. And you can see some filling.
This is the way doctors will talk when you're laying on the bed watching TV.
He's saying I talk too much.
I never let a man cook, but you.
There you go. Guys, that's it. I hopefully we've at a very high level reviewed what MS does to the central nervous system. We touched on when to try and have a therapist intervene in your journey with MS. And then we really focused on spasticity and management of spasticity related as specifically as we could to MS. So that's all I got for you. Any questions? Yes.
So your team at Westport, I love Louis. I've had a man crush on 2 people. One of them was Dr. Louis, and he's a he is. The stories he tells me while he's putting that needle in my calf. Yeah. I mean, he's amazing.
One of the best storytellers I know. I see more of him than I do of my wife. No, we joke about that. I mean, we've known one another for, oh, geez, I might cry. Chris and I met in 1999, so he's a lot older than me. I know you don't believe him, but he is. But that's because he did a PhD in MS-related research in Milan before he went to medical school. But we only trained 2 years apart. So we've sort of developed this program together. I think it wouldn't have happened had it not been a tandem doing this. So And we've got to see and do a lot because of it. So very thankful to have him in my life. He's great.
Dr. Ishmael, the type of therapy that you do, I know a few of our members have drop foot. Would that help people with drop foot?
It could. So sometimes drop foot but typically it's happening because of weakness in muscles in the front of the leg, which lift the foot up. But sometimes it presents as drop foot, not because of weakness here, but more because of tightness in the back. So if you have tight calf muscles, they'll pull your foot down. So by injecting the calf muscles and maybe even giving you a splint and ankle foot orthosis, which maybe many of you have seen, it'll help to lift that foot or allow you to use the muscles in the front to overcome the tightness in the back. So it may present as drop foot, but it's not really drop foot. It's pseudo drop foot. It's because of tightness of muscles in the back.
Doug has a certain contraption on his leg to help with this. He was just wondering if your treatment would alleviate.
Would require an examination, but yeah.
My socks are a little smelly.
I've seen it all. It's fine. And smelt it all.
Socks are the feet. Oh, maybe that comes with I never get to the feet part. Oh, I see.
Like, I commend you guys for sitting through an entire afternoon. That's a lot of information. I only got to see some of Dr. Lee's slides, but that's a lot of heavy science. So yeah, I can see that. The questions were just remarkable. Any other questions? Fairly straightforward, fairly self-explanatory.
Thank you.
No problem at all.
Do you take care of the incontinence issues?
I definitely can. I mean, I haven't touched on that today because it wasn't the focus, but yeah. But at some point it may require the intervention of a urologist as well, and urodynamic studies. And
I've been there now for about 4 years. And, okay.
yeah.
So we could get a referral for that problem, so this problem, or so on.
I mean, they've got a great clinic at Lyndhurst called the Robson Clinic. Now there the focus is spinal cord injury, but it's not that they don't see patients with MS-related bladder issues. I remember that as a resident. And
I've been taking medication. First it was, what was that first drug? Now it's neurobergeron, but first it was something else that you can call cognitive tetral. And then I found
Yes.
out that caused cognitive issues, and that's what she did get. So I wonder, can we see you for that problem, or should we?
I would probably go directly to the urologist at Robson Clinic because they are specialized in those with neurological conditions. I mean, again, primarily spinal cord, but they do see patients with MS. So there's a subset of urologists that deal with patients who have neurological conditions that are causing issues with the bladder.
They're also accessible, so people require
Exactly.
because they work primarily with the spinal cord. It is a medical referral, so if you have, you would need, the referral is easy to get, but it needs to be filled out by a doctor, physiatrist, or a GP. No, I'm staffed at Toronto.
Well, we're all going to be one happy family as of April 1st.
We're all gonna be-
Yeah.
Which is great.
No. Yes.
If someone was prescribed back years ago when they were able to stand, now that they're no longer able to stand straight in a wheelchair, should they still be taking them back with them?
That's a great question. You know, the only answer I have is it helping the current level of muscle tightness that they have? So we can chat after, absolutely. Okay. You know, so we're allowed to chat. You give me permission, right? I have your consent. It's supposed to keep the muscles looser by working on. Yes.
Too strong in his knees with buckle.
Correct.
Or whatever.
Right.
That's whatever, it might be too stiff, you know, there's
But now he doesn't stand that, like, he doesn't.
So is there tightness anywhere else would be the question, in the arms, for example. And if there isn't, right? Exactly. And you won't know until you start to slowly wean him off of it and see if the tightness increases. So you don't have to get to 0. You can get to half the dose that he's currently on, for example, under medical guidance, right? Under the supervision of a physician. and see if things are tightening up again. And if they are, you have your answer. So then you take him back up to the dose that he's currently on. Because although you're in a wheelchair, there still may be some benefits, because if you take him off the baclofen, the legs may tighten up and then transfers become difficult. Dressing and undressing the lower extremities becomes difficult, right? Things of that sort become challenging. So it would be best done under medical supervision.
Well, when he stretches, like he's in bed or has to get up and then all of a sudden he gets that, when he stretches, I cannot move his legs like that guy that's been trying to move part of the bed.
So there may be a role here for baclofen plus something that's more focal to help alleviate what it is you're describing, if it's causing a functional problem. Again, just because it's there doesn't mean it needs to be treated. If you're able to manage with it, then there's no need to inject for it. But there may be a role here for injections just based on what you're sharing with me. Okay? You're welcome.
Dr. Ismail,
Yes.
I want to thank you for your time and your expertise.
Thanks for the
And spending the afternoon away from your family with us. We're very fortunate that we're becoming part of West Park. So I'd like to present with you a check for $5,000 for your clinic,
Thank you so much.
as well as we have a orientation as well.
Thank you so much.
And we're looking forward to, for some of those who might not know, one of the rehab rooms at West Park is being named after my MS family for our financial benefits. So we're looking forward to that tour, and we're looking forward to bringing a lot of patients to your office. I know you see a couple of our members now. I know Teresa's seeing you in the new place in April. About the end of March? Okay. So, but thank you so much. We are privileged that we have connected with the absolute best of the best.
It's kind of you to say. Thank you so much. This is going to go towards, it's going to go towards, I think, an ultrasound machine to help us sort of treat patients more adequately. So that's where we're going to suggest this goes. So thank you so much. Thank you so much. It's very much appreciated. Thanks a lot.
So before everybody leaves, you gotta take a sandwich home with you. Okay, I don't plan to gain weight by eating the rest of the sandwich. So help yourselves. There's some coffee left over. Thank you so much for taking the Saturday afternoon. Bridget, thank you so much for coming up to Toronto. I know a lot of our members would like to speak to you. Do you have business cards? Any of the cards?
I don't. You can find me at West Park. I'm the only Farouk Ismail there, I promise. Yeah, I am.
Okay.
Yeah.
So we have some of our MS brochures.
My sister says.
We give you some of our brochures.
Absolutely. Please do.
Thank you.